keep to time to make sure that everything is running well. And we have 10 talks, and I'm really looking forward to this. And the first one up is Zin Toot, who's talking about enhancing adrenal vein sampling, the role of plasma metanephrines in diagnosing primary aldosteronism.
Thank you, Prof. Good morning, everyone. My name is Zinto, and I'm a clinical research fellow at Imperial College London. Today, I'll be presenting our study on enhancing adrenal vein sampling, the role of plasma metanephrines in diagnosing primary aldosteronism. So just a bit of background, as we know, adrenal vein sampling is a gold standard procedure for differentiating unilateral from bilateral disease. And because unilateral disease is treated surgically and bilateral disease require medical therapy. Current guidelines suggest using cortisol for adrenal vein cannulation and aldosterone neutralization, but it has limitations that cortisol may be co-secreted by adrenal adenomas. So instead, plasma metanephrines could be a better alternative as it is unaffected by adrenal adenoma co-secretion. So our study aims to assess plasma metanephrines for adrenal vein cannulation and aldosterone neutralization, and also to define optimal metanephrine selectivity index and lateralization index cutoff. This is a retrospective study from January 2018 to May 2023. We had a total of 131 unstimulated EUS procedure in 129 patients, and all patients had confirmed, biochemically confirmed primary aldosteronism according to Endocrine Society's guideline. AVS interpretation criteria for cannulation success, cortisol selectivity index above 2, and to identify unilateral disease, AC ratio, which is lateralization index above 2. And in our center, we use contralateral suppression index less than 0.5. So to confirm unilateral disease, we need both cortisol lateralization index above 2 and contralateral suppression index less than 0.5. So baseline characteristics, we had 129 patients in total. So we have 129 patients in total who underwent a 131 AVS procedures, average age around 50. As we expect in patients with primary aldosteronism, they all had biochemically confirmed hypokalemia, average potassium around 3.0, lower suppressed RNA, and hyperaldosteronism. We also look at the size of adrenal adenomas, which average around 12 millimeter, but there's some variability as well. So it's generally small adenomas in patients with primary aldo, and most patients require at least 2 antihypertensive medications. So overall, baseline characteristics consistent with what we expect in patients with primary aldo. So here we got ROC curve on your left side, and this is to show how well plasma metanephrines predict cannulation success. So as you can see here, the area under the curve close to 1, which is excellent accuracy. And looking at the table on your right side, as you can see, successful cannulation was confirmed in 129 patients according to both cortisol and metanephrines. And 4 patients had failed cannulations to both metanephrines and cortisol. So only 1 patient had discordant results that failed cannulation with metanephrines, but not with the cortisol. So overall, metanephrine selectivity index above 3 was optimal with sensitivity of 99% and specificity of 100%. To establish the lateralization for aldosterone metanephrines ratio, we excluded 9 borderline cases based on aldosterone cortisol ratio. So that's leaving 117 patients in total out of 129 successful cannulation cases. So here we got raw curve on your left side, and the area under the curve 0.95, which is excellent accuracy. Looking at the table on your right side, 69 patients got unilateral disease, confirmed with both cortisol and metanephrine lateralization index, and 41 patients got bilateral disease according to both cortisol and metanephrines. So out of 117 patients, we got 110 concordant cases and 7 discordant. So metanephrine lateralization index above 4 had sensitivity of 93% and specificity of 95% in confirming unilateral disease. We also look at the data for patients who underwent overnight dexamethasone suppression tests. So out of total 126 successful cannulation cases, so 72 patients underwent an overnight dexamethasone suppression test to exclude or confirm mild autonomous cortisol secretions, and 14 patients failed the test. So if you look at this graph here, y-axis, we got serum cortisol level in nanomole per liter, patients who failed the test in red dots, and patients who passed the test in the blue dots. So 14 patients failed the test, and mean cortisol level was around 67 nanomole per liter. What's interesting here is that out of 14 patients who failed the test, 4 patients had discordant results. So patient number 2, 5, 6, and 8. If you look at this third column, these 4 patients, they had AC ratio suggested bilateral disease. However, AM ratio suggested unilateral disease. So all 4 patients underwent unilateral adrenalectomy, and histology confirmed adrenal adenomas, and they all achieved complete remission. So these are the characteristics of patients who underwent adrenalectomy and evaluated using the PASO criteria. So PASO stands for primary aldosteronism surgical outcome criteria. As this is a retrospective data, we don't have the post-operative outcome for all patients who underwent adrenalectomy. So total 76 patients underwent adrenalectomy, and we got clinical outcome data in 36 patients and biochemical data in 37 patients. So if you look at this table, 21 out of 36 patients achieved complete clinical success, and most of the patients achieved complete biochemical success. Another thing is low BMI, its p-value less than 0.05. It's observed in patients with complete success compared to the partial responders. Otherwise, there's no significant difference in the rest of the data. However, patients who achieve complete success, both in clinical and biochemical, they have more unilateral findings on the CT scan, and histology show classical pattern, which is adenoma, so which is solitary aldosterone producing adenoma. So this is a definition of success of primary aldosteronism, PASO international consensus, how we assess the patient 6-month post-op follow-up. So it's depend on the outcome measure for clinical and biochemical. So for clinical, we have complete clinical success, partial clinical success, or absent. So complete clinical success means normalization of blood pressure, patient not taking any further antihypertensive medications. Partial success defined as blood pressure better, requiring less antihypertensive medications, or absence of clinical success. And for biochemical, complete success means serum potassium back to normal, and also normalization of aldo-renin ratio. And partial success means more than 50% reduction in serum aldosterone level. So we normally monitor this blood test, potassium, renin, aldo, when we see the patients at 6-month follow-up clinic. So in summary, plasma metanephrines selectivity index above 3 had 96% concordance with cortisol selectivity index above 2, and metanephrines lateralization index above 4 had 94% concordance with cortisol lateralization index above 2. So incorporating plasma metanephrines into AVS procedure that enhance lateralizations, especially in patients with aldosterone cortisol co-secreting adenomas that we discussed earlier in our 4 patients. I would like to thank to our team, our interventional radiologist, Dr. Ali Asafi, who is a single operator who performed all our AVS procedures, all our endocrinologists, Dr. Rennie, who is a lead investigator, our clinical scientists, our endocrine specialist nurse, and surgeons. Thank you very much, and I'll be happy to take any questions.
Many thanks then. Questions? Obviously very interesting finding that in particular the cortisol co-secreting, it's informative.
Thank you.
As you would wish, yeah. Question there and then.
Just one question, should it be mandatory that any patient be worked up for a
Yeah, so guideline also recommend checking overnight dexamethasone suppression test for all patients diagnosed with primary aldosteronism.
Yes, because obviously the experience is previously,
Yeah.
this was only case reports, but we are more aware of this, that patients can get into adrenal crisis if they had significant cortisol co-secretion. Yeah, should be.
Thanks a lot. Very interesting. I just wonder, are you performing rapid cortisol measurement during the procedure? And if you do, though, this probably is not possible for metanephrines. Or how do you deal with this? Are you then still rely on rapid cortisol measurement during the procedure?
It's about localization, you know, like you can do intraprocedural cortisol. Can you do intraprocedural plasma metanephrines?
Yeah, we don't do interprocedural cortisol. And
Yeah.
so it's something you do in.
Yes, and we have very good experience.
Yes.
with this. And you, at least our radiologists are with this procedure even better. Therefore, you just showed only the positive results, but the question is how many are failing? And therefore, this, at least in our center, we could increase this number or reduce the number of failing procedures
Yeah,
significantly.
you can even do cortisol measurements at bedside, and that has also been shown to enhance the positive, the informative procedures, which is great. Very interesting stuff then.
Thank you, Prof.
Over to Florian.
Thank you. So it's a great pleasure to welcome Professor Mark Gunnell from Cambridge, who will tell us about advancements in imaging, functional imaging for adrenal tumors.
Thanks very much. Well, thanks, Vibke, Florian, and Kareem for organising what I'm sure is going to be an excellent day. I apologise that James isn't here to present. James is actually doing 3 adrenal ablations, or at this way he's at the sharp end anyway, being the endocrinologist. As we do those ablations, we sort of looked at each other and said, if we're doing an adrenal ablation, it goes wrong, who do we want to be in the room? And I got sent here. So what I'm going to do is I'm going to present on behalf of a lot of the work that James, and in particular Dan Gillett, but also loads of other people in this room, and you're going to hear from Emily shortly afterwards. This is very much a real team effort. So here are relevant disclosures just for me. We published this article recently just highlighting where we still have a lot of shortfalls in the care of patients with PA, and I won't dwell on it too long, but there's still a lot to be done in terms of getting the diagnosis. If we don't get the diagnosis, then we're actually going nowhere. There's lots of developments in this area. I won't focus on that now. Also, increasingly, the question of lateralization, I think, is truly moving to localization. And therefore, do we have the techniques available to do that? We've just actually heard about how tricky AVS can be. There are those centers which actually do super selective AVS, but actually that's probably beyond most people. Actually, even getting successful AVS is a tough ask. And if you ask people to actually spend another hour or 2 in the cath lab trying to get down individual tributaries, that's not so popular. We're going to hear from Emily shortly about some innovations around alternatives to adrenalectomy. And then, of course, not far away are the aldosynthase inhibitors, and that probably is going to make a significant difference to us in day-to-day practice. But I'm going to focus really on the diagnostics and in particular the role of potentially of imaging. So the Endocrine Society guidelines, which are under review at the moment, and I reminded myself as I was commenting on them yesterday, for the new version, which is about to emerge, essentially have a pathway. Diagnosis, CT or MRI, AVS, then adrenalectomy if you've got unilateral disease or otherwise medical therapy. But we all know there's lots of hurdles on this pathway. And in addition, there is a substantial bottleneck. And again, wherever you go, there are relatively small numbers of individuals across geographical locations who are capable of doing high quality AVS. And I'm not sure if I was needing an investigation, I would want to go to somebody who said it's 50-50 whether I'm going to cannulate both adrenal veins. And yet we really should be honest about that if that's what the local data says. I actually have to stop at this point and say, your interventional radiology here is absolutely staggering in terms of uncannulated AVS. Do not let him retire. But we're never going to solve the problem with AVS. So a while ago, and when Maurice Brown was in Cambridge before he then moved down to Barts and QMUL, we'd actually been trying to pick up on some of the work of others. So this is work which actually also has origins from a Würzburg perspective, but also from our colleagues in various Scandinavian locations about using molecular imaging. And initially, I had this title as alternative, but as we've increasingly seen, it's actually potentially you can put these two investigations together and push even more patients over the line. So the reason I went back to this is the very first patient that we actually did a metomidate scan on in Cambridge back in 2009. And the reason I highlight it is because it highlights a couple of key messages. One is that metomidate does bind CYP11B1 and B2, but we turn it into a predominant B2 binding ligand by pre-treating the patient with dexamethasone and therefore actually suppressing B1 expression. And that's a 3-day course, unlike the 10 or 14-day courses that people used to do with normal cholesterol scanning. But the other thing that this patient, I think, beautifully exemplifies, and so here, you might just be able to appreciate a tiny little nodule here. Obviously, there's uptake in the adrenal, but the addition of the dexamethasone allows us to actually see the nodule more clearly because we actually suppressed the background. And actually, this was actually probably one of the first times we started thinking localization, not lateralization for PA. And therefore, could we actually manage a patient in a slightly different way? Others have done some nice studies. This is a prospective study by Troy Poor in Singapore, which essentially found that actually when you do head-to-head of AVS and metomidate, as it was here, the metomidate performs just as well as the AVS. And intriguingly, this study showed what we also then went on to show is that these investigations find different patients lateralizing. So they're not all identifying the same patients. So AVS is a gold standard, but I would argue no longer the gold standard because it doesn't find some patients with unilateral disease. And I haven't got time to summarize this enormous piece of work, which is the MATCH trial, which is Zilin, who's not here today, but many others in the room were part of, which was the study which has essentially shown comparability between AVS and molecular imaging, i.e., although we set this study asking ourselves if it was superior, it certainly was non-inferior with a potential suggestion, if you like, on the non-inferiority study that actually for each of the outcomes on PASO criteria, molecular imaging was certainly as good, if not possibly slightly better. So, amazingly, this pathway looks to me like it's going to still be the pathway in the 2025 guidelines. But I've only seen a brief glimpse of it. But we would like to propose that the pathway should have an accelerated pathway to it, which is potentially to use PET-CT. And actually, one of my aspirations is actually just to cut everything else out and just go straight in with an original PET-CT, one lot of imaging, high-quality CT and PET. Now, the one problem with metomidate is the half-life. So at the moment, in the UK, you come to Cambridge because that's the place making metomidate. It's a 20-minute half-life. You need to be in the building before we scan you. So what we started to do is to think out what other tracers could we potentially use that might actually allow us to scan more patients. And as we thought about this, looking at the various potential tracers, a fluorinated tracer has the advantage of the half-life, which is really critical, much longer, but also the actual range of the positron in water, which is really, really crucial for the quality of the image you get. So just to compare, for example, 68 gallium, and there is a ligand 68 gallium pentixaphore. One of the challenges with gallium is the spread of the signal. So you don't get as sharp a picture. And when we're looking for small lesions, You want something which is very, very short on that length. And this is actually a simulation which shows you how, if you actually use different tags for imaging, potentially here in a model, you get much clearer pictures with the ligands at this end than you do potentially down here. The gallium does work. This is kindly provided to me by Linus Haberbosch and Linus Hess, who are in Berlin. And this is a patient who failed on AVS in terms of right cannulation, but you can see that there is an obvious lesion. But the problem with the pentixafor at the moment seems to be the resolution. Once you get to a centimeter, it's quite difficult to be sure that you're actually seeing what you think you're seeing. So instead, we had been working in a collaboration, which was a Cambridge, Barts and Uppsala collaboration to develop CETO, which is a derivative of MTO. So don't forget, both of these are derivatives of etomidate. And beautiful pre-human studies done by the Uppsala team demonstrated this is a very, very selective adrenal tracer. And actually, it seems to have another advantage compared to MTO, which is it's got very low liver uptake. That means we actually see the right adrenal better with CETO. Long story short, this is work that Dan has just published in JNM. We were able to show in healthy volunteers as well as patients, and also pre and post dexamethasone, that the adenomas still show lots of uptake on a time course, whereas the background gland is suppressed, which is an important part, remember, of switching things off, but the uptake everywhere else is really, really low. And this is beautifully just published by Emily, literally this week on Monday, in Annals of Internal Medicine. This is part of the story of the match extension, which is a head-to-head of metomidate and CETO. And I hope I can persuade you, these are the same patients scanned actually on different days, and the scans are remarkably identical to each other in terms of ability. And perhaps this case, as it runs through, will illustrate that. So you'll see that this patient has a lesion coming up over here on the right adrenal. Notice the MTO is taken up in the liver. Notice with the appropriate windowing, there's 0 CETO in the liver. If you can try and now do what a radiologist does, Andrew, so try and look at 2 things at the same time. This is way beyond me, but try and look at both of them and see whether you can spot much difference between the scans. And I would argue that from the adrenal perspective, these are incredibly similar to each other. So this helped us to be persuaded that this CETO is potentially a replacement. This is a piece of work that's under review at the moment. This is an individual voxel level analysis in the 31 match patients in the match extension. This is measuring every single voxel on the MTO and comparing it with the paired voxel on CETO. And these are incredibly similar. And the only difference is the right adrenal, where there are some slightly high SU values, which is almost certainly the liver, the overlap on the edge of the liver. So at voxel levels, these are really, really very similar to each other across the many tens of thousands of data points that are in the data. And just to reassure you that this is moving quick, this is now an NHS approved tracer. So we did 104 scans last year in 9 months. We've done 36 scans in January and February this year. So capacity-wise, I think this now actually potentially moves us up a different gear, because that's us doing ACTH-stimulated AVS with actually not a bad success rate, but we're never going to be able to deliver this amount of testing. So briefly to finish, the dexamethasone is really, really important here, because actually without it, this ligand is both a B1 and B2 ligand, whereas if you actually give the dex, it reduces. And we knew this was important from the match extension, the match study, because if you have a nodule with B2 in it, it's hotter than a nodule with B1. So we do need to be checking dexamethasone cortisols, probably looking at ACTH and DHES, because you can see that we can often now see really tiny nodules in the adrenal, but sometimes the uptake is lower or nearly close to the background. And intriguingly, in a patient where you can definitely see some evidence of MAX, as Emily will now show you in a moment with the ablation studies, we can actually biopsy these and determine that the hotter lesion is B2 and under dex suppression, the cooler lesion is B1. And we then actually applied this now with a new technique looking at the resolution of the tracer. These are all lesions with the same concentration, they're just different sizes. And the problem is you don't see things as clearly when they're smaller as you do when they're bigger, despite having the same amount of tracer. And we need to understand this if we're going to find small lesions. So Dan has made these amazing 3D printed radioactive tracers. His wife is the radiation protection officer in Cambridge. Not sure what she made of this when he went home. But anyway, these are artificially printed and put in the PET CT, and we can now see lesions of different sizes. And the important thing is how you handle the data depends on whether you see both lesions, which you know are there, because it's a phantom that you've created, or whether you can't see them because the imaging software doesn't process it in a way that allows you to detect. And this means that we can now start to detect small lesions that we really struggled to see previously. And in particular, for example, where lesions are actually virtually no hotter than the background, with the resolution of CETO, we can see very, very tiny lesions. And this is a very tiny nodule in the left adrenal that we can now pick up and actually therefore theoretically target. There are other tracers coming. I can only tell you about what we've worked on, but I would argue that this is a very exciting time for PA because there's a huge amount of ligands potentially coming through. And I think for the first time, we'll get into a position where we really can offer patients the options for potential definitive interventions. I need to finish by doing this. This is not possible without all these people, many of whom are sitting in the room, but I think it goes to show the power of collaboration. And thank you to everybody else who's done it. And thanks for your attention. Thanks for the invite.
Thank you, Mark, for this fantastic overview. Any questions?
About the debt suppression. Can you do it overnight? Or does it?
I've noticed you put 3 days of
Yeah.
debt suppression, but
So-
can you do it with overnight debt suppression? Will that work?
So when we first did this, we kind of thought we really don't want to invent a ligand that's 10 or 14 days again. That's going to be really difficult. But almost certainly, looking on modeling, kinetics from an enzyme perspective, it's probably very unlikely that an overnight DEX will do enough to switch it off. But we've not actually done that. We went in at 3 days, and it seems to have been a fairly fortuitous estimate of where to go.
Let's ask a question. What sort of timelines do you foresee that the new tracer will be more widely available for clinical practice? Or
So for CETO, yeah, so the PEC contract is up for negotiation this year. So Scottish NHS has now established a centre in Aberdeen, which Glasgow will lead. So there's now a Scottish service for CETO. There's a service now in the Netherlands. There's a service in Denmark. Calgary now has a service. My plan is to go to NHS England and see whether we can actually get them to approve more centres. And that's, in the current climate, that's always going to be an ask. I think what we need to do is to reassure them we're not about to open a total floodgate, which will spend the entire PET budget. But actually, the one advantage here is now we can do, off one production, we can do 6 patients, 4 in Cambridge, 2 down at Barts, and that makes the cost of this much cheaper.
Your prediction, very nice data, but your predictions that the aldosynthetase inhibitor tracer, they will be, because then you don't need any DEX if they are specific enough. And when will they take over? Though then CETO will be gone.
What will happen, I think, is that we'll have to learn, because with the aldosynthetase inhibitor, I think we need to be careful we don't get paralyzed in decision making. Because if you start seeing lots of little things in both adrenals, the question will become at what point you feel confident to actually do anything to the patient because of fear. Whereas here, we've got a very good feel, as we'll see, as to where actually the thresholds sit. And also for CETOs, you'll see this afternoon, the beauty is this is not just applicable in PA. It's now applicable in other tumours, other cortical tumours. So I think this tracer will have dual roles. But I think the aldosynthetase inhibitors are very exciting, but I think we need some big data to understand whether it causes more tricky decision making. If you start seeing little nodules everywhere, it'll be interesting to see when you act.
Oh, great. And we continue in the same vein and have Emily Goodchild present to us, not on the paper that just came out, but on endoscopic ultrasound-guided radiofrequency ablations of aldosterone-producing adenomas. Looking forward to it.
Hi everyone, I'm Emily and I work for Professor Brown and Professor Drake at Barts and Queen Mary. And I'm going to talk to you about something we're calling targeted thermal therapy, which is the endoscopic ablation of aldosterone-producing adenomas. So primary aldosteronism, as you know, is the dysregulated production of aldosterone, which leads to resistant hypertension and carries twice the cardiovascular risk of primary hypertension. And it's really common, affecting up to 13% of the normal hypertensive population. So we used to classify it as a dichotomous distinction of either bilateral or unilateral, as shown here, but we now see it more of a spectrum of a disease with a combination of aldosterone-producing micronodules and nodules, giving rise to autonomous aldosterone release commonly from both glands. And this has led to us to move more towards referring to patients with primary aldo as symmetrical and asymmetrical rather than bilateral and unilateral. And this work is all about the solitary APAs that you can find. So the traditional approach, as Mark just said, is about, which is unchanged for the last 30 years, starts with an aldosterone to renin ratio. You get confirmatory testing, which patients have to pause their useful medications for, a CT scan to confirm a nodule, an AVS, which again is off the interfering but working medications. And then 50% of patients are found to have bilateral disease treated with largely poorly tolerated mineralocorticoid receptor antagonists, and the rest go for laparoscopic adrenalectomy, ideally. So why do we need to change anything? Well, our capacity for surgery in the UK is about 300 for primary aldosteronism per year, and that out of a total predicted unilateral primary aldosterone population of 1.4 million people. We don't really have the opportunity to upscale to that kind of level. Also, the collateral damage, even if there are no complications to the surgery, the whole adrenal gland is removed. It's sometimes hard for me to remember that there are other zones in the adrenal besides the ZG, but apparently there are, and it seems a shame to remove the whole gland for just the purpose of removing just a few millimeters of non-malignant disease. Also, our recent patient engagement work demonstrated that patients are actually really attached to their glands and they would rather hold on to them. And we were surprised, even in the face of a lifetime without medications, they'd rather keep their gland if they can. And so we also have complications with surgery, as you know, all of the complications of major abdominal surgery, and also the associated risks of general anesthetic, and of course, the chance of having to convert to an open laparotomy. All of this seems a little bit much in the case that only about 23.5% of patients at 2 years have complete clinical cure, as demonstrated by the match data. A lot more have biochemical cure, but for people not to be taken off all of their medications, it seems quite a lot to go through for just that. So what can we do instead? To address this worldwide need, we're working on less invasive options to treat asymmetrical primary aldosteronism. And first is the percutaneous adrenal ablation, which we're calling external targeted thermal therapy, ETTT. And that's where a needle, which heats the tissue near to its tip, in our case by radio frequency or microwave ablation, is inserted under CT guidance through the soft tissue and into the nodule. And this can be administered to nodules in both the left and the right gland. And here's an example. There's the left nodule, and there's that big old needle going in under CT guidance, where you discharge the ablation of whichever type you like, and then you have this sort of halo smoke effect afterwards. And this is an established therapy, but because of the risks and the low efficacy, it hasn't really been rolled out into normal practice. Risks include the challenging nature of the procedure, takes a little while. There are general anesthetic risks, hypertension during the procedure, visceral perforation, and also failure, especially on the right-hand side. The IVC acts as a heat sink and so can make it ineffective. So next I'm going to talk about internal targeted thermal therapy, ITTT. And this is a procedure that we've developed, which under ultrasound-guided transgastric radiofrequency ablation is discharged through the stomach wall as an alternative to left-sided percutaneous ablation. And this technique capitalizes on the fact that the adrenal on the left side directly abuts the stomach. And so this rather frightful-looking endoscope with an ultrasound probe and needle attached is placed into the stomach and the needle is deployed. And so patients are pre-treated with alpha and beta blockade prior to the procedure to mitigate the risks of catecholamine release at the time of the ablation. They attend the endoscopy suite for a day case procedure, which is carried out under sedation. So here's a still ultrasound image to orientate you to what the endoscopist can see. This is the stomach wall, which is 7 millimeters away from this hypoechoic lesion, which is the adenoma. Here's the lateral limb of the adrenal and the needle and the medulla there. And energy is delivered in a series of short burns, 10 to 20 seconds long. And that's guided by the ablationist. from what they can see. And that's significantly less time than the percutaneous, which is sometimes 12 minutes of continuous ablation. So during the procedure, a fine needle biopsy is taken, and this provides tissue to give both a pathological confirmation and the opportunity to make a genetic diagnosis. And these results, taken from the recently published Fabulous study, show on the top line the H&E stain, on the second line aldosterone synthase staining, which demonstrates the diagnosis of primary aldosteronism, and then on the bottom you can have a look for CYP11B1 as a surrogate for cortisol production. And from the Fabulous study, these are the results of the genetic diagnoses, ATP1A1 being the more common, ATP2B3, the cacnade, calcium channel mutants, and then the potassium channel mutants. And we can use that information in the research arena to prognosticate for patients and plan their follow-up. One of the major benefits is, in future, we may be able to deliver triple T therapy to both sides. So patients with bilateral troublesome disease as disease burden reduction, or even potentially cure. And if it doesn't work, if an ablation doesn't work, we can go again. We can go and ablate another nodule in the same side, or we can later go back and ablate a nodule in the opposite side. And surgery is still an option because you've still got your adrenal tissue. And we've done surgery on patients who've had ablations before, and it doesn't affect the quality of the surgery. It does affect the laboratory analysis of the tissue because the tissue is fried. So I wouldn't recommend trying to genotype those guys, but there we are. So the WAVE study that we're doing now is asking, is ablation a good alternative to surgery? We know that ablation wouldn't be as good as surgery in terms of the biochemical and clinical cure because you're not taking away the whole gland and all of the micronodules and small nodules that exist in the rest of the zona glomerulosa there. But the intervention is so much less invasive, it may just be worth it. So you can just keep going back if you need to and still fall back on surgery if there's still a problem. So we're looking at this prospective trial, a randomized controlled trial comparing laparoscopic adrenalectomy with the triple T therapy. And here are the first 6 consecutive patients. So I haven't cherry picked. And these are their CT images that Professor Gunnell mentioned before and after the procedure. So you can see that little hot spot there with the yellow and the red around it. That's the adrenal nodule. Before the procedure, it's hot, and after, it is not. Here's participant 2, similar. Participant 3, less of a difference. Participant 4, still hot on the before and cold afterwards. Same again for participant 5, and again for participant 6. So radiologically, we get really good results from these procedures on the left side. And just to go into a little bit more detail on a couple of those cases, case 1 is a 65-year-old gentleman who had resistant hypertension on 4 antihypertensives. He had biochemical evidence of primary aldosteronism. His scan before showed a really nice juicy nodule on the left, and afterwards that has been ablated successfully. And 6 months following his procedure, he was normotensive, off antihypertensive medications with biochemical cure, but most importantly to him, his quality of life was hugely improved because he hated taking medicines, but also for personal reasons didn't want to have surgery. Case 2 is a 50-year-old gentleman who had a blood pressure which was high on 2 antihypertensives, biochemical evidence of primary aldosteronism. Before he had a nodule, you can see here. But on the sagittal, you can see that there are actually 2 nodules which weren't imaged in this axial image. He had an ablation and only one of the nodules was ablated. And that's because during the procedure, it wasn't possible for technical reasons to ablate the second one after the first one. And so at 6 months, he remained hypertensive on antihypertensive medicines with biochemical evidence of primary aldosteronism. And so he'll be going for a second ablation where we'll confidently be able to target that second hot nodule and hopefully treat his primary aldo. And finally, case 3 is of a 49-year-old lady who had a right-sided lesion with hypertension on 2 antihypertensives with biochemical evidence of primary aldosteronism, treated with percutaneous radiofrequency ablation or external triple T. And you can see that's perfectly cold on the post-ablation scan. And she is now normotensive, off antihypertensives, but we're waiting her biochemistry. So these are some illustrative cases of potential outcomes from these triple T treatments. And in summary, primary aldosteronism is a common and dangerous condition for which accessible diagnoses and treatment are immediately necessary. To address this, we've developed a functional imaging targeted approach by using CETO PET CT scans to administer a minimally invasive treatment, which has been demonstrated to be safe and effective. And where there is the option to ablate adrenal nodules, percutaneously on the right, external triple T, and endoscopically on the left, internal triple T, we're currently working to complete the randomized control trial comparing triple T with surgery, and always welcome your referrals. Here is the team. And here are some QR codes that you can have a look at these references. So this is the Fabulous trial, which is published in February. Here's the rematch trial, which is the 2-year follow-up trial from the match study, which is the comparison of AVS and functional imaging. And then here is the patient information sheet and inclusion criteria for the WAVE study, in case you fancy referring to us, and the email address is on the bottom there if you do. Happy to take questions.
Many thanks, Emily. Very promising first results. Yeah. Cool. Questions from the floor? Stand silent.
A bit more about the safety. So you mentioned it's safe, and but did some patient complain about pain or any other even more severe complication? Probably not. But even, what was the perception from the patient perspective?
So the Fabulous study was primarily a safety study, and we have here the SAEs from that, which include an episode of atrial fibrillation in a patient who had very low potassium the day prior to the procedure, which is why we now check the electrolytes beforehand. I think because there's kind of like a torrential release of aldosterone stored in the cells, and then that can lead to the effects of hyperaldosteronism shortly after the ablation. And then we've also got somebody who had an episode of pneumonia post-procedure, who had to stay in hospital for a little bit of extra time. We had a patient who had a STEMI due to the general anaesthetic at the early stages of this trial. We were administering the treatment under general, and there was an undisclosed history of ischemic cardiovascular disease, which was really unfortunate. And then this final patient had an episode of hypertension during the procedure. Again, this was another patient who was under general anaesthetic in the early stages of the trial, where the patient actually received some spurious anaesthetic agents, which led to that episode of hypertension. So, so in general, it's well tolerated, and on the whole, patients go home the following day, and they are back to their normal activity of daily living really quickly.
So can you remind us again of the study flow diagram? Yeah, like you had the one where you say this and that, where they are randomized.
Yeah, this one.
Yes, exactly. Yeah, like sort of, so enrollment, obviously you would want unilateral adenoma. So how is it determined?
So we choose people who have an adrenal nodule of 1 centimeter or more. It's 1 centimeter to less than 2.5 centimeters. And
so you do AVS or?
So they have AVS procedure, or they have functional imaging, or both.
Or both. Yeah, like I was just wondering whether for systematic things, I would have had this CT also in any case before the laparoscopic adrenalectomy, so that you can be sure of diagnosis.
Yeah, so to get in, to be enrolled, they have to have demonstrated unilateral disease, yeah. And they have to have the laparoscopic adrenalectomy patients don't need the localizing functional.
And that's CETO, not M2.
CETO.
Yeah, I think it would be cool to have CETO also in the other group, but whatever.
I mean, it would be cool for sure.
Yeah,
it probably wouldn't benefit them.
Because then it would be more clear what the basis is.
Yes, that's true. Yeah.
Great. Florian.
Thank you, Emily.
Thanks so much.
Thank you.
So we move on to our next speaker. It's Lucas Bouy from Paris, who has recently joined the MRC, and he's going to talk about KDM-A1 in primary macronodular adrenal hyperplasia.
Thank you. Thank you, Florian, for the introduction. So yes, I'm a French endocrinologist, and I recently moved to London here in the LMS as a Chain Flory TTI fellow. So we are shifting from frequent diseases to very rare diseases. I will present you the results of my works done back in Paris about KDM1A mutations in primary macronodular adrenal hyperplasia and my current research project here in the LMS, which is the logical continuation. No. Okay. So I will call it PMA to shorten. So PMA, if we try to define PMA, it's the presence of bilateral adrenal macronodules more than 1 centimeter in diameter and associated with variable levels of cortisol excess. This is a rare disease and a rare cause of Cushing syndrome with a mean age at diagnosis around 55 and a clear female predominance. Given the bilateral nature of the adrenal involvement and the description of familial cases, the genetic predisposition has always been suspected, and more than 10 years ago now, the first genetic cause has been found with the identification by my former group in Paris of the germline heterozygous inactivating mutation of ARMC5. ARMC5 acts as a tumor suppressor gene. It follows the 2-hit model of tumor suppressor gene, which is namely, first a germline inactivating heterozygous mutation, which is always constantly associated with somatic mutations in the adrenal nodules on the wild type allele, and this results in the biallelic inactivation of the gene. Since then, more than 10 cohort papers have been published studying ARMC5. ARMC5 is considered now the cause of around 20% of PMA index cases and around 80% of familial cases. ARMC5 mutations are associated with a more severe phenotype in terms of intensity of Cushing syndrome, adrenal morphology, and metabolic complications. So back in 2020, we wanted to dig further into the molecular characterization of PMA. So we performed a multi-omic analysis of 50 samples from 36 patients with PMA who have been treated with adrenalectomy. And in short, if you look at the RNA-seq analysis, we see that in the blue group, what we call the G1 group, it was only nodules from ARMC5 variant carriers clustering, so in a very homogeneous molecular group. They also had a recurrent loss of heterozygosity of the short term of chromosome 16, carrying the ARMC5 locus, and this is the second hit in 1/3 to the half of the nodules of these patients. But we also noticed that there was a recurrent loss of the short arm of chromosome 1 in 6 patients who actually were also clustering together in this red group in the RNA-seq that we call G2. So we performed the germline exome sequencing of these patients and found germline inactivating heterozygous mutations of KDM1A, and KDM1A is mapped on the short term of chromosome 1p1. So if we look closer to the RNA-seq, you see that KDM1A is the most underexpressed gene in the G2 group compared to the 2 other groups. And then one of the most overexpressed genes in this group is GIPR. So GIPR encodes the GIP receptor, which is involved in the rare condition, which is food-dependent Cushing syndrome, described more than 30 years ago, characterized by a very low fasting plasma cortisol, dramatically increasing after food intake. And this is actually mediated by the aberrant expression of GIP receptor in adrenal cortex. So GIP, as you know, is an incretin secreted by the duodenal K cells following food intake. It binds its receptor normally expressed in beta cells to promote insulin secretion. But in the case of food-dependent Cushing syndrome, GIP receptor is also expressed in adrenal cortex. Thus, GIP acts in the same way as ACTH by stimulating cortisol secretion, but only after food intake. And indeed, all 6 mutated patients had a food-dependent Cushing syndrome. So after we had identified these mutations in a very limited number of patients. We wanted to screen KDM1A mutations in a larger series of patients. So we enrolled 301 PMAH index cases from 8 European, Brazilian, and American centers and performed targeted sequencing of ARMC5 and KDM1A. So we found 10 patients with 9 different germline inactivating mutations of KDM1A, which represent around 3% of the series. All the KDM1A patients were women. All had a food-dependent Cushing syndrome, and no food-dependent Cushing syndrome was found in neither wild-type or ARMC5 patients. KDM1A patient had also a more severe biochemical Cushing syndrome, and in line with the pathophysiology of food-dependent Cushing syndrome, they had a lower morning fasting cortisol, a higher midnight cortisol, and resulting logically in a much lower morning over midnight cortisol ratio. So it's represented here, it's more visual. So when below 0.65, this ratio holds a 100% sensitivity for the detection of a food-dependent Cushing syndrome. And then for a KDM1A mutation, that makes it a good tool for first screening, but it still needs to be corroborated by the confirmation of cortisol stimulation by oral glucose load or mixed meal. So at that point, we have mainly answered the clinical questions, which have logically raised scientific questions, which will be the purpose of my stay here in the LMS for the next 3 years. First, which mechanisms the KDM1A inactivation results in the aberrant expression of GIP receptor in the adrenal cortex. KDM1A encodes the histone demethylase, primarily demethylating histone 3 on lysine 4, which is a transcriptionally active mark. So KDM1A is considered a transcriptional repressor. So we can speculate that a normal KDM1A can repress the expression of GIP receptor in adrenal cortex, and and that this inhibition is lost in the case of the inactivation of KDM1A, leading to the expression of GIPR in adrenals. But this is not demonstrated yet, and this might be way more complicated than that. And given the pivotal role of KDM1A in the regulation of transcription, we can expect that the transcription of many other genes will be dysregulated in these patients. If we look to the sex dimorphism, the female predominance is quite common in adrenal diseases. Both benign and malignant tumors affect preferentially women, which represents usually between 60 and 70% of these patients. But in the PMAH associated with KDM1A mutation, now there is, I think, 41 reported cases in the literature. 38 of them are women, so it's around 95%, which is unprecedented even in adrenal diseases and quite unexpected for a dominantly inherited disease. So the questions that we might ask, we could imagine a protective role of androgens on adrenocortical tumorigenesis, as that it has been already described like 2 years ago in mice with adrenocortical carcinoma. KDM1A could be differentially expressed between men and women and could also regulate the transcription of the genes located on the X chromosome. So I would like to explore this hypothesis during my stay here. And finally, about the tumor suppressor gene notion paradigm. So as I mentioned earlier, tumor suppressor gene model implies that the patient have a germline heterozygous mutation, and always in their somatic cells, a somatic event affecting the same gene on the other allele and leading to the biallelic inactivation of the gene, and that the biallelic inactivation of the gene is a condition to promote tumorigenesis, but also is sufficient to promote tumorigenesis. This model has been described like more than 50 years ago. It has always been believed that the somatic mutations occurred like randomly during development and aging without a specific pattern. But a team really, very recently, it's like last week in Nature Genetics, demonstrated for NF1 in this case that the somatic mutations of NF1 occurred way more frequently in patients already harboring a germline mutation of NF1, which is the first demonstration of that. And also that the B allelic inactivation is not a sufficient condition to promote tumorigenesis because they have a lot of cells with both alleles mutated without any abnormal features. And in the case of PMA, both AOMC5 and KDM1A show very different variants in terms of somatic mutations. If you take a single AOMC5 patient in his adrenal nodules, he will have different somatic mutations in every nodule, whether by a single nucleotide variation, frame shift variant, or a loss of heterozygosity of the short arm of chromosome 60. This has been reported recently. While KDM1A patients will always have a 1p loss of heterozygosity in their adrenal nodules. So it's very different. It's also a question I would like to investigate. So in conclusion, KDM1A is a tumor suppressor gene causing the rare condition of PMA with food-dependent Cushing syndrome. The germline screening of KDM1A should be offered to patients with PMA and evidence for food-dependent cortisol secretion. And KDM1A shows a very strong somatic molecular homogeneity with constant LOH. These are the questions I would like to explore here, I just mentioned. And for that, I hope that I will be able to use this very new and interesting tool, adrenocortical-like cells derived from induced pluripotent stem cells, who have been reported by Kotaro Sasaki 2 years ago, and which will host me in his lab in Philadelphia in a few weeks, and I'm very looking forward to it. Thank you for your attention.
Thank you very much. Any questions?
That was a really great talk. The KDM1A, presumably it's not crystallized yet, but you've been able to do some modeling based on other 7 transmembrane domain receptors. Can you then do some prediction around what the mutations that you've seen in the patient will do to the function of the receptor itself and how it might interact with ligand or with the heterotrimeric G proteins and differentiate signaling downstream?
So it's very recent, the link between KDM1A and GIP receptor. It seems GIP receptor in this condition seems to be completely normal. But we also know that GIPR is not the only transmembrane receptor overexpressed in this patient. They also have LH, HCG receptor overexpressed, but without like clinical relevance. But we don't know much more yet about this. But
Lilly have produced a drug which inhibits glucagon-like peptide 1, or sorry, mimics that and GIP. And our, in our hospital, I suspect, maybe in a year we start 100 patients a year on this drug, which has GIP agonism. How long do you think before we've caused our first case of Cushing's through this mechanism?
I think if no GIP receptor is expressed in the adrenals, there is no risk for Cushing syndrome, but maybe this will unmask an unknown food-dependent Cushing's ignored until then. But so again, 41 cases reported in the literature is very, very rare. But yes, maybe that could emerge one more, but I don't think so. It will cause as itself Cushing syndrome.
Any other questions?
So with all these mutants, are you planning to express them having taken out the original wild type receptor and express those mutants and see what they do?
Express mutants in
a cell system?
Yes,
to see how
this is the plan. This is the plan.
Yeah.
By developing the adrenal light cells, I would like to introduce, like by CRISPR-Cas9, KD1A mutations, and also other gene mutation, ARMC5, AR1A, and C. On GIP receptor, it's quite obvious. It will be overexpressed, like one other group have demonstrated it by inhibiting KD1A in H295 our cells, but it will be more interesting. It will be the mechanisms, like to see the histone marks of KD1A in these cells, and maybe all the other genes. I think it will be numerous.
One more question regarding the sex difference. You seem to be quite sure that it's the androgens, but it could be the estrogens which are responsible. What is the sex, the age distribution on the patients? So are they patients or these female patients in all ages, or
mostly in their 40s? At diagnosis, mostly in their 40s. But
this is still premenopausal, so it could be also the estrogens who are.
Yes, it could
different.
Be. No, the hypothesis of like a pejorative role of estrogens, maybe. Yes, it could be. The hypothesis of androgen protective role was in my head, based on the work of Pierre Val in Clermont-Ferrand in ACC in mice. So it's very far from our disease, but kind of related. And maybe it was through the recruitment of a specific macrophages and that androgen could protect it. But of course, no hypothesis is put aside.
Many thanks for that.
Thanks.
And we have now Sarazam Chowdhury speaking to us about Pred-8 steroid prescribing in adrenal insufficiency. We are saltish on time.
Okay, so my name is Sarazam Chowdhury. I'm going to be presenting you the findings of the Pred-8 study. This study was conducted here at Hammersmith Hospital. It was funded by the NIHR as part of my doctoral research fellowship. And I'm very excited to tell you what we found, actually. So there are two drugs that are used predominantly in the UK for adrenal insufficiency. We've got hydrocortisone that's used in about 72% of individuals, and prednisolone used in about 26%. This data comes from data collected within the UK primary care between 2010 and 2016. The two pertinent guidelines here are the NICE guidelines from last year and also the Endocrine Society guidelines. Both of these guidelines indicate that we should be using hydrocortisone as first-line treatment, and they suggest rather that we should be using 15 to 25 milligrams in divided doses. Prednisolone is listed as an alternative in these guidelines. However, its uptake hasn't really gained much traction. At Imperial, we're using it far more commonly. So our uptake is, when I show you the data later, it looks almost close to 50%, and it may even be more. The reason we've got such uptake for prednisolone here is that about 10 years ago, I developed a mass spec assay to measure prednisolone levels. And using that assay, we've managed to convert patients from hydrocortisone to prednisolone. And we've used day curves, we've used 8-hour levels to titrate doses to get patients on the lowest possible dose and keep them safe. So I don't think I'm going too far in saying that we've probably pioneered the use of low-dose prednisolone in this condition. So the study is relatively straightforward. It's a double-blind crossover study. Patients were randomized either to 4 months of prednisolone, followed by a washout period, followed by 4 months of hydrocortisone, or the opposite, where they were randomized to 4 months of hydrocortisone, followed by a washout, followed by 4 months of prednisolone. The study itself had 3 study visits. There was day 1, which was a baseline visit where patients were on their open label medication. Day 30, where we collected 1 month interim outcome data, and day 120, when we collected final 4-month outcome data. And these study visits were repeated on both periods on both drugs. So blinding is essential in a study like this, and it was quite a challenge. So we had our tablets specially made for the study. They were made in China, they were shipped to the Netherlands, they were packaged as IMPs and then sent to the UK during Brexit. So it was remarkably difficult and stressful, I might say. I lost many nights of sleep. However, what we ended up with is that each patient was given 3 bottles. And regardless of whatever drug they were on at the time, they were told to take a single tablet from each bottle. Now, if they were on prednisolone, then their morning bottle contained a tailored dose of prednisolone. It was either 2, 3, 4, or 5 milligrams. And to maintain the blind, they had a placebo at noon and a placebo in the afternoon. When these individuals were on hydrocortisone, they again got their own tailored dose. We were able to accommodate these regimens in the morning bottle, these regimens in the noon bottle, and these regimens in the afternoon bottle. But the point is that the 3 bottles contained hydrocortisone, hydrocortisone, and hydrocortisone. The aims of the study were to compare hydrocortisone and prednisolone on a number of outcomes. The primary outcome was bone turnover. And the reason we selected this is that we know that osteocalcin in particular actually responds very quickly. So it adopts a new baseline within about 7 days. In terms of secondary outcomes, we used more routine markers of bone turnover. So that's procollagen P1MP, that's urinary NTX. We also looked at surrogate markers of cardiovascular risk. That's things that were measured, so anthropometrics, observations, as well as serum markers as well. In terms of glycemic outcomes, we looked at HbA1c, glucose, insulin. Infection rates and well-being were monitored using questionnaires, so the GNCQ for the former, and for the latter, we used the Adrenal and the SF36. And safety was measured using frequency and occurrences of adverse events. I won't have time to go through all of the findings, so I'm going to go through the most salient and the significant ones. So we had ethics to recruit 55 participants. We were expecting about a 20% dropout rate. We needed 44 individuals to complete, and that was to enable us to detect a 1.5 micrograms per liter difference in osteocalcin levels with a 90% power. All of our patients had to have adrenal insufficiency, and therefore they were recruited from outpatient clinics within London, actually, although we had ethics to go to the whole of the UK. All participants were diagnosed by their parent teams with adrenal insufficiency, and they must have had it for at least 6 months. Those with secondary adrenal insufficiency had to be stable on their other hormone replacements for at least 3 months. As you can imagine, the exclusion and exclusion criteria are far more exhaustive, but if you want to know more about them, I have some slides at the end. If a patient had not been on one or the other drug, meaning that they were either naive to hydrocortisone or prednisolone, then it became important to put them through a 2-week dose-finding period. So in that period of time, they were given a test regimen of either drug that they didn't see before. And what we did is we tailored them or tapered them down using whatever tools are at our disposal to the minimum dose we could get them down to in a reasonable time frame. And that was done for 2 purposes: 1, to get them on the lowest dose, and 2, to ensure that they were actually safe to be on that drug. So this is the patient pathway through the study. A patient would be identified in an outpatient clinic. They'd be referred to us. They would go through a screening and eligibility check. Then they would go through a 2-week dose finding period if it was needed. Then they would be randomized to either prednisolone first or hydrocortisone first. And then they would attend visit 1, where they would have their baseline data collected. On that same day, the study drug would be dispensed. We would be blind to it. They would be blind to it too. And then at home on day 2, they would start taking their medication, replacing their normal open label medication. So the reason to put this schema up on the screen here is to demonstrate to you that visit 1, visit 2, and visit 3, they were stereotyped. Everything happened in the same way to ensure that the patients were familiar with our process. That was to try to reduce their stress levels down. Additionally, all of the studies were conducted in the morning. We tried to keep to the same times, and that again was to limit the circadian effects on the outcomes of our study. This is an example of what might happen in the first study period on prednisolone, perhaps, and then the next study period would be the same thing, but on hydrocortisone. So this is my consort diagram. We screened 72 individuals, of whom 47 were recruited, of whom 24 ended up on prednisolone first, and all of these individuals got through to the end. 23 were randomized to hydrocortisone first. Unfortunately, we had 1 withdrawal in the first period for personal reasons, and then 22 completed. Now, the baseline characteristics is a very, very full table. I'm going to try and get the angles right here. But most of these groups here, you can see are balanced. The exception here is that you can see that prednisolone first arm was slightly younger than the hydrocortisone first arm. The other interesting point to show you is that we did manage to get 1/3 primary, 2/3 secondary adrenal insufficiency. That's in keeping with the population at large. And in terms of the baseline steroid doses, sorry, down here, the majority were on, or the median even, were on 3 to 4 milligrams. And for hydrocortisone, it was 20. The minimum hydrocortisone dose we had was 17.5, and the highest was one individual on 27.5. What you see here are the interquartile ranges. So these are more baseline characteristics, but these are all the parameters that we look at the end. Now, the one to point out to you is weight. You can see that the prednisolone arm unfortunately started slightly heavier than the hydrocortisone arm, although I would argue it doesn't really make much of a difference because this is a randomized crossover study. So each patient is their own control, and the baseline value is what we compare to at the end. So moving on to the results. So this is the primary outcome. Now you're looking at on the left here at carboxylated osteocalcin, and this is undercarboxylated osteocalcin. This is a bone formation marker. This is a bone resorption marker. But the short story here is hydrocortisone, no real change. Prednisolone, there's a drop in carboxylated osteocalcin. The treatment difference is minus 1.22 micrograms per liter. For hydrocortisone, for undercarboxylated osteocalcin, hydrocortisone causes it to go up, prednisolone causes it to go down. These are some other bone markers. So these are actually used more routinely in clinical care. Urinary NTX, you can again see that hydrocortisone causes it to go up, prednisolone causes it to go down. The net treatment effect is that prednisolone causes a reduction. And with P1NP, it's essentially the same story. To summarize these two slides, what I'm telling you is that prednisolone suppresses bone markers, hydrocortisone makes them go up or they stay the same. In terms of surrogate cardiovascular risk markers, weight, interestingly, we saw prednisolone causes weight loss, hydrocortisone causes weight gain. The net treatment effect was a loss of 1.87 kilograms with prednisolone. With and then moving on to waist circumference, though I appreciate the graph doesn't quite demonstrate it, that there's a difference in the stats that we use. So you're looking at medians here, whereas we used linear mixed modeling for the statistics. So we have estimated marginal means that you can't really graph. But the point is that hydrocortisone was associated with a positive 2.26 centimeter increase in waist circumference. And then in terms of glycemic outcomes, HbA1c basically goes up on hydrocortisone and comes down on prednisolone. And that's a minus 1.23 millimole per mole treatment difference. Now, this slide, I'm showing you just to demonstrate that with Adequol and 3 of the 9 SF36 domains, that there was actually no difference in well-being between the two drugs. And that was repeated across all of the questionnaires and the infection rates as well. In terms of adverse events, we saw 133 adverse events in 37 participants. 67 occurred on prednisolone, 60 occurred on hydrocortisone. The eagle-eyed amongst you will notice that the numbers don't add up to 133. There were a couple of adverse events while patients were on their washout period, which I haven't included here. The most common adverse events in keeping with the literature was actually a viral illness. That's the leading cause. There were 34. Lethargy was next, and then COVID was after that. We had 3 severe adverse events on the study. They all happened on prednisolone. One patient had hyponatremia, who we think was probably an SI-ADH patient in hiding. We had a viral gastroenteritis who required hospitalization. We also had, I say an acute gastroenteritis, that's the MEDRA for it, but in short, it was food poisoning. It was dodgy takeaway. So, conclusions. I've demonstrated to you that hydrocortisone and prednisolone clearly have divergent effects on bone turnover. Prednisolone is clearly causing suppression of resorption and formation markers. Hydrocortisone is either causing them to stay the same or for them to go up. I can't really tell you what this means because when you look at the literature, the clinical significance of bone markers is not so clear, and we didn't really expect this finding. The signals from this study are that cardiovascular outcomes appear to be better with prednisolone, and that's by virtue of what we've seen with weight, HbA1c, waist circumference. Importantly, there is no difference in well-being or safety between these treatments. And here are my acknowledgements, and without these individuals, this study wouldn't have been done. So thank you.
Many thanks, and that's obviously a great pilot study. So I torture you right away, like sort of, it's about the average glucocorticoid dose. Yeah, like sort of, you said prednisolone was 3 to 4 milligrams, and hydrocortisone was 20 milligrams, and 3 to 4 milligrams prednisolone obviously translates into 12 to 16 milligrams hydrocortisone. So that means you treated with a lower dose, which means you had slightly more beneficial effects, but more adrenal crises.
Yeah, so we didn't get any adrenal crises here. None of these AEs were adrenal crises. They didn't quite meet that threshold. But I would dispute what you've said there. So ultimately, when you look at the relationship or the bioequivalence of prednisolone to hydrocortisone, especially at low doses, it's not 1 to 4. It's more like 1 to 6 to 8. Our data indicates it's more like 1 to 7. So 3 to 4 is more like 21 to 28 milligrams, I would argue. And when you look at the previous data as well, where prednisolone has been used, it's usually used at 5 milligrams to 7.5 milligrams. And that's where the detriment to bone has been listed and demonstrated in the past. So I would argue with you, the characterization isn't quite right. And even when you go back to where this 1 to 4 came from, it came from 2 posters at one conference in 1960, for which the data was never seen. So it's very...
There are a few more, but like sort of the thing is to power it for a study where you look at safety. Yeah, like sort of, and because you need to see likelihood of adrenal crisis and then take the power from there for large scale study.
So I would argue with you that's something that needs to be done in future. The point of the pilot study is there's hesitance to use prednisolone. It has bad rep. And really, we need a short-term outcome study to demonstrate safety to clinicians in the first instance so that we can push forward. I strongly do believe, though, that the data here and some of the other data we're producing, it really does look like the cardiovascular benefits are superior with prednisolone. And it's important that this is there, that people look at it, and then we do the long-term mortality morbidity studies.
Let's look when you build on the pilot study, but like it's a very good start. Okay, questions?
Thanks for a great talk. I was just going to say, if you don't think it's a dose difference really between the hydrocortisone and the prednisolone, why would prednisolone be better? Like,
so I have a slide for this. I'm going to struggle to get it up. I think there's 2 factors here. So one is steroid exposure. So prednisolone is being given in the morning as a single dose. Hydrocortisone is given multiple times, right? So if you have a drug that is given multiple times, then the area under the curve goes up almost exponentially. So exposure to hydrocortisone is far higher with a triple regimen. With prednisolone, it's going to be lower. Prednisolone is more avid at the glucocorticoid receptor, and it has different effects downstream as well. But there's area under the curve, i.e. exposure. And then number 2 is the timing of exposure. So if an individual is getting hydrocortisone 3 times a day, it's very likely that there's carryover later into the day when the body becomes sensitive to glucocorticoids. I actually subscribe more to the latter argument, because when you look at some of the data that comes from Prednisone, which is modified release hydrocortisone, they're getting very similar results to what we're getting with prednisolone. So there's a paper by Jorgensen et al. 2024, so last year, where their HbA findings after 4 months of Prednisone, very similar to ours. Their bone marker findings, almost the same. So it's very interesting. I think we're missing a massive piece of the puzzle, and I think it's the timing of dosing.
Yeah, I think I would endorse this. Yeah, like in particular, as you give a single morning dose of prednisolone and not like many others do morning, evening, which is detrimental because of the longer activation of the glucocorticoid receptor.
Yeah,
I agree with that.
Just a couple of questions. So I was wondering if you'd looked at any of the sort of free hormone dynamics. So if you'd managed to look at salivary prednisolone, maybe take a day curve of this to see, I mean, potentially you could almost be precision medicine for each patient, because CBG will be different in each patient, and you may be able to optimize that further. And just second question, which is more expensive if it's a
But for the larger study that follows now, that would be good. So like, so you should check this James Hawley. Yeah, like sort of who obviously has all these essays. And saliva is anyway great because people can do this at home.
Yeah, precisely.
And just pop it in a pre-stamped envelope into the post.
So salivary cortisol, cortisone, prednisone is growing, and I think it's a wonderful thing. With regards to the study, that wouldn't have been possible because it would have unblinded, first of all, and we didn't have, so to give you a bit more background, we started this in 2019, and I ran it through the COVID pandemic, which was a nightmare. So it overran by 3 years. We only finished in 2023 December. It was only meant to be 2 years, took 4.
It's not for the large scale study, you can integrate this. You couldn't do it in
No.
this instance, but for the
Next one,
study,
potentially, yes.
yeah, I think. Because neither the
Store it and
clinician-
do it at the end, potentially.
Yeah, exactly.
Yeah, to be honest, we didn't plan for it. Salivary also hadn't taken off at the design. What was your second question? Pardon me. Cost. Okay. So hydrocortisone historically from about 2011, I want to say, was very, very expensive, in the order of about 120 odd pounds for a 1 month supply, whereas prednisolone has stayed relatively stable at £1 to £3 per month. At one point, the NHS was paying an excess of £69.5 million for hydrocortisone because of a scandal in the pharmaceutical company or pharmaceutical industry.
Yeah. So that's definitely a good argument. Okay, cool. So we give you a special applause for standing your ground and for doing this stuff to avoid COVID.
Very kind. Thank you.
So next speaker is Dr. James Pittaway from Queen Mary University in London, and he will talk about DLK1, a novel biomarker and therapeutic target in ACC.
Thank you very much. And thank you for the opportunity to present some data from my PhD, which was done with Professor Leonardo Guasti at the Center for Endocrinology. So my talk is going to be on protein DLK1 as a novel biomarker and therapeutic target in ACC. Now, adrenal cortical carcinoma is a rare malignancy with a heterogeneous prognosis, which is particularly bad when disease presents in the later stages, as it does in over half of all the cases. And over the last sort of 10, 15 years, there have been these large pangenomic analyses looking at the somatic mutations that are in these tumors. And there are some common pathways that are affected, particularly those involving adrenal organogenesis and self-renewal. And so looking at other proteins that are in these processes has been a way to potentially identify new biomarkers. And DLK1 is a marker of adrenal self-renewal. Now, DLK1 stands for delta-like non-canonical Notch ligand 1, and it's a transmembrane protein with a cleavable ectodomain, and it's an atypical Notch ligand, and it's paternally expressed, and like many such paternally expressed proteins, it's found at high levels in lots of tissues in the developing fetus, but then after birth, and then as into adulthood, it's low or absent in almost every healthy tissue. However, it is overexpressed in many other cancers. In the adrenal cortex, we have shown that it is a stem progenitor marker in the rodent, in the developing cortex, certainly through embryogenesis. And in human adrenals, there is a very similar to sort of APCCs as there were, or APMs now. You have a continuous layer of DLK1 expression through earlier life, and then into the sort of 30s and 40s, there is a reorganization of the cortex to create these DLK1 cell clusters, as you can see on the panoramic image there. And these cell clusters phenotypically are lacking the terminal enzymes of steroidogenesis, and so therefore are less differentiated. And some preliminary work in a very small number of samples from biobanks published in 2019 showed that in ACC, however, there was a much higher expression level of DLK1 than was seen in the normal adrenal cortex or in aldosterone-producing adenomas. So that really set up the study for my PhD and going on. So from 2016 onwards, we've been collecting samples of suspected adrenal cortical carcinoma from Bart's, UCLH, and here, and also from Bart's collecting samples of non-malignant adrenal pathology as a control. And the initial look was using immunohistochemistry for DLK1 expression in these samples. How did it compare between ACC and what ended up being other pathologies, a lot of adrenal adenomas, and then some other non-adrenal benign and malignant lesions. And in the small research samples that we received, we didn't have whole tissue sections for this. There was a significantly higher expression of DLK1 in ACC than we saw in the other groups. Now, this is an example of this. What is this? That one. Okay, so this is an adrenal gland, and here's the tumor coming out from it. And this is an immunohistochemistry for DLK1 with DAB staining. So wherever it's brown, there's DLK1. And you can actually see it's a nicely specific antibody, and you can see a DLK1 cell cluster there. In fact, I've even highlighted it. And so this is kind of what the immunohistochemistry looks like. And we can objectively quantify this now with QPath, which is an open access software, which if anyone hasn't used and does this sort of thing, I could highly recommend. But we were slightly restricted in the fact that we had these small research samples and a small number because it's a rare condition. And so I had the opportunity to go to Professor Fasnacht's department in Würzburg and look at a much larger cohort of ACC. And this was a total of 178 different tumor sections in 159 patients. And that's because in some patients, there was the primary tumor and also some recurrences or metastases. And this really encompassed the full sort of clinical spectrum of ACC in terms of the different NSAT stages of presentation and the different hormonal stages of presentation, different sort of hormonal profiles of presentation as well. And what we found is that DLK1 expression was essentially ubiquitous in every ACC studied, and it was commonly heterogeneous. We could see another nice image here with some normal adrenal glands and physiological DLK1 expression in their cell clusters, and then a huge tumor abutting out of it with a very sort of clonal population of DLK1 expression. This is also seen here. It's quite clonal in its expression level. However, DLK1 expression appeared to be sort of unaffected by the other prognostic factors that we know affect ACC. So NSAT stage being a common influencer of prognosis at the time of diagnosis, there seemed to be a spectrum of expression, which was the mean expression level was seen the same throughout the NSAT stages and throughout the different hormonal presentations of disease. We also saw that the DLK1 was expressed in the recurrence disease. You can see quite nicely there is a metastasis in a lymph node and a metastasis in the liver. And interestingly, the brown speckling in the background of the liver are hepatoblasts, which are physiological sites of DLK1 expression in a non-disease setting. And in the same patients, when we looked at the primary tumor and their secondary tumor or metastases, there was a constant sort of level of DLK1 expression with a strong positive correlation. So looking at the level of DLK1 expression and asking whether it had any influence on sort of prognostic factors, if we ordered all of the DLK1 expression from lowest to highest and split this into quartiles, there was a increased risk of disease recurrence with a higher level of DLK1 expression versus lower. And you can see that that is a sort of dose-dependent sort of effect in the way that the lines are fanning out. We saw a very similar picture with progression-free survival, which is a slightly different survival metric where the patient doesn't have to have been disease-free at any time. But this didn't quite reach significance. And looking at this with a sort of multivariate Cox regression analysis, DLK1 was independent as a risk factor for recurrence and very close to statistically significance for the same in progression also. Now, as I said, this is a transmembrane protein with a cleavable ectodomain. And so under the influence of TACE, this is cleaved, and we don't actually really know what the receptor is, but we posited it might be detectable in human serum. It's known that normally it's almost undetectable in human serum in physiology, except at the late stages of pregnancy, where it's actually fetally derived. And so we were prospectively collecting blood samples from all of our patients, and then found that not only was it detectable in patients with adrenal lesions, but it was significantly higher in those who ended up having ACC versus non-malignant adrenal cortical lesions and any other sort of non-adrenal pathology. And this actually provided, although quite a small number, a decent sensitivity and specificity in terms of predicting malignancy just from the blood test alone. In order to study this further, this was validated in some samples in Würzburg, and these samples were not selected for the study in particular. It was available serum to be studied whilst I was there. And all of these patients had ACC and at different disease states at the time that their serum was studied. And interestingly, the patients who had the primary tumor in situ, who had a more widespread metastatic disease, had much higher levels than seen in the other disease states. So there might be a role as an adjunctive role for the diagnosis of ACC, but potentially also in the longitudinal follow-up of patients. And given what we know about the prognostic relevance of DLK1 expression in tumors, wondered whether there was a relationship between the DLK1 expression seen in the tumor and also measured in the blood in the patients that we had both. And in the London cohort, there was, looking at all of the pathology together, there was a positive correlation, but this was seen much more clearly in the sort of ACC alone population when looked at in Würzburg. And in the small number of patients where we had post-operative DLK1 levels, there was a drop after surgery in all of these patients. And so suggesting this is a tumor-derived phenomenon and therefore something that, that might be useful for a longitudinal follow-up. Now, the final bit is just to give you sort of an update as to DLK1 as a potential therapeutic target. If you were to pick an antigen to design a drug for any new therapy, you would want it to be something that's expressed on the cell surface, something that is preferentially expressed in a malignancy and has much lower and has low to absent expression in all other healthy tissues. And DLK1 ticks all these boxes, which is why the sort of DLK1 research world is full of lots of people trying to generate new drugs. And the first one, which is getting a little bit of sort of press in terms of different studies being published at the moment, is a drug called ADCT-701, which is there's a company called ADC Therapeutics, which has generated the drug initially with hepatocellular carcinoma in mind. And this is a DLK1 monoclonal antibody, which is conjugated to a cytotoxic agent, which is pyrrolobenzodiazepine. And this has been shown, certainly in the preclinical studies, to be very effective in neuroblastoma, which is another malignancy with high DLK1 level of expression. They've also, in a sort of preprint version, there's some evidence that this works nicely in myeloid leukemia, which is associated with Down syndrome. And also, there is a group in the NIH who've looked at this in adrenocortical carcinoma. However, unfortunately for this group, they have found that DLK1 expression in adrenocortical carcinoma cells is often in the presence of an ATP binding cassette called ABCB1, which happens to efflux this cytotoxic compound. And therefore, it wasn't really working in their preclinical models, and they've investigated as to why, and this is the reason. So this agent is not going to be useful for ACC, but this approach might be because there are other cytotoxic compounds that aren't effluxed by this. Another potential approach for targeting it might be CAR-T, which is also getting some increased academic interest for solid tumors. And there is a group that has proven in mice that there is some success of doing this in hepatocellular carcinoma. I know Professor Fastnack's group has got some data on this using a different antigen. In ACC, this is potentially a harder strategy given the glucocorticoid exposure and from the disease and the influence that might have on the T cells. But that is an area that potentially could be for investigation. And finally, some monoclonal antibodies cause an antibody-dependent or a complement-dependent cytotoxic cascade anyway. And so this is something that has been shown in a liver model as well. And in our lab, Katim Maraniello, who's our postdoc, has used an in-house phage display to generate a fully human DLK1 monoclonal antibody, which we've called adrenotumab. And we're currently characterizing that for study in terms of mechanism of action, in terms of which one of these avenues we might want to go down. So in summary, I've hopefully shown that DLK1 is a ubiquitous finding across ACC and is associated with increased malignancy, that serum DLK1 levels are detectable in ACC, and this is a simple benchtop ELISA. So this could be something that could be available in every clinical setting, and that these correlate with tumor expression levels. And we're in the final throes of putting together an NSAP proposal to look at this on a much larger scale, both prospectively and retrospectively. And DLK1 is a preferential target for novel therapeutics in ACC, and so watch this space with old adrenotumab. And I'd just like to thank everyone, both at Barts and in Germany, and all of our funders. And thank you very much. I'm happy to take any questions.
Fantastic. Thank you very much. Any comments?
Great stuff. I certainly knew already some of this. Great. I have a little bit different question regarding the serum effect. Or the point is you realize, or it's obviously present in the serum. Everything what is present in the serum might have any effect. Right now, do you have any idea what's the physiological role of this? And if this might lead to potential side effect of your nice adrenal, which I like a lot.
Yes. So no, I mean, I understand the question, and no, we don't have any idea exactly what might happen. I mean, there are sort of it has been targeted in other models using different things. We don't know with any confidence what the receptor is of the ligand yet. I mean, it is likely to be likely to enact most of its activity through some Notch signaling. We don't know the physiological significance of this, and DLK1 exists in two isoforms physiologically and in cancer, one which is more fixed and one which is cleavable. And so the ideal thing would be to potentially try and target the one that doesn't get cleaved. But we don't know this yet. We don't know this yet. So we'll have to start to see. But it's not a problem that seems to have been happening in the other cancer settings in the preclinical models with off-target effects as yet. So we will see.
Thank you for working. Yes, thank you. It was very interesting. I have one question. Do you have any evidence that DLK1 is a driver gene in ACC, or just is overexpression could be just a result of other molecular mechanisms?
I don't think it is a driver. I don't think it is a driver. I mean, it's an expressed imprinted gene, obviously. So it would be a nice one if there was some loss of heterozygosity thing. But I don't think it is. And there is now a mouse from Boston where they have a P53 inactivating beta-catenin overactivate, driven by aldosynthase. And so essentially all these mice will develop ACC with 99% penetrance at some stage during their life. And looking at these mice, this is adrenals, at different time points, there is not a sort of upregulation of DLK1 as the tumor is developing. It's sort of not really there. And then as soon as it develops, it's there at high quantity. And then it's even higher in the metastases. So I think it's more of a reflection of the molecular landscape change in a term of reversion to some sort of stem kind of phenotype rather than a driver mutation. Yeah.
I might have missed it, James. How does it differentiate between benign and malignant adrenal tumors? Did you test this?
Yes. Yeah. So it's I mean, so from the serum level, there is well, I won't go back, but then from the serum level, it's much higher in the malignant tumor, significantly.
So do you think it can be used as a diagnostic test?
I think as an adjunct, again, I don't think it's something that you're going to be basing your entire decision on, because the data that we have thus far, although they're sensitive and specificity around 80%, I mean, it's not good enough. You can't leave an ACC in someone and then et cetera, et cetera. But it might be something that as part of a diagnostic workup, if it was included, its main clinical translatable use might be in the longitudinal follow-up, because we know that it's raised in patients that don't have steroidogenic disease, for example, so you don't have another obvious biomarker.
So what kind of sample volume do you need for the DLK1 serum assay?
Sample 100 milliliters. Yeah.
Okay, cool.
I think we have
Great, and now we have Shiba Jarvis, who is an Imperial postdoctoral post-CCT fellow, and she will talk about her results on understanding the role of nuclear receptor-regulated lipid pathways in ACC.
Perfect. Thank you very much for the invitation to present a short presentation around some of the research I'll be doing as part of my postdoc fellowship. Understanding the roles of nuclear receptor-regulated lipid pathways in ACC. I'll go through a background to the study, some preliminary results, basically screening for nuclear receptor expression and signatures in ACC, and tell you about one of the nuclear receptors we've been focusing on, again, preliminary data, testing the effects pharmacologically of manipulating that particular receptor in ACC cell lines. So James has given me a fantastic primer in terms of how serious and concerning this disease is. It's rare. We have a lack of targeted effective treatments. The genomic landscape's been well characterized, but that hasn't yet been translated to effective targeted therapies. And despite sort of the Cancer Genome Atlas and other sort of aspects around molecular heterogeneity that we've learned, over the years, this has posed a problem. And here in that sort of picture, I'm not going to zoom because that's going to go wrong. Hold on. Okay, so we can see that within this ultra rare disease, there are subtypes, and cluster analyses suggest different genetic signatures. It's unclear what drives progression overarchingly. There are limited effects with immune checkpoint inhibitors, which have been transformative in other cancer types. And there are many unanswered questions around sort of metabolic heterogeneity, alterations in the lipid signature, and other classes of targetable actors that may be receptors that one could pursue, and thoughts around drug repurposing. This is sort of just a snapshot. So just before I kickstart things, we know from a macroscopic perspective on imaging, there are clearly altered lipid profiles when we make sort of diagnostic decisions. We know here in this is histological representation of 2 patients with a benign tumor, and this is an oil red O stain that shows that this is a lipid-rich benign adenoma. And we know lipids in the context of normal physiology are clearly important for steroidogenesis, for signaling as fuel, and in cancer there is a lipid switch that ensues, and certain lipids can act as oncogenic cues. And here in the right panel, this is an ACC, 2 representative patient samples with no real sort of lipid staining. So let me tell you about nuclear receptors. In case you don't know, these are attractive targets in cancer biology. Some are druggable, and they control a suite of genes that are involved in cancer and also normal processes, physiology, development. And they've been successfully manipulated for therapeutic gain in other types of cancers. There are 48 nuclear receptors, different classes, the well-known steroid hormone nuclear receptors, orphan nuclear receptors, which sounds very sad. We don't know what their ligands are, metabolic nuclear receptors. And the typical representation of a nuclear receptor is they all have different sort of caveats, but generally you have a ligand binding domain, the said ligand will bind to that, and the DNA binding domain of the said receptor will then stick to its DNA on a consensus sequence and regulate various target genes. And here on the right is a nice screenshot from David Mangelsdorf's work, showing some of the classic nuclear receptors. So the first nuclear receptor out of the block that was characterized was the glucocorticoid receptor, followed by ER, THR, and so on. And in the 90s, we had sort of a big bang of understanding of identifying newer nuclear receptors that make up that 48 member superfamily, and a whole host of understanding around co-regulators and how these work, X-ray crystallography to try and understand the structure of nuclear receptors, and the holy grail sort of making a lot of them druggable. So the scientific approach in this was really to characterize nuclear receptors and identify significant nuclear receptors that are dysregulated in ACC. And then I'll tell you a little bit about one of the nuclear receptors called liver X receptor, which we've been manipulating in cell lines, and some of the LXR regulated targets and pathways in cell lines. So AIM-1, step 1 of my project was really to try and find a slightly shifty way of working out what the nuclear receptor signature was in ACC. So AI, a few years ago, where it was kind of newer than we are now, basically in silico medicine designed a software called Pandaomics. Initially it was called Pandomics, but it was a pandemic and it all got confusing. Anyhow, long story short, you bring together transcriptomic data for idiots like me as a clinician. You then bring around data around key opinion leaders, patents, other aspects, to say which of these particular nuclear receptors in this instance may be good targetable things, very useful for pharma. So here is basically a table which shows you 6 publicly available data sets where there have been genetic testing of ACC versus normal adrenal or benign. And here we brought together these data sets, 6 of them in a meta-analysis style, to basically pull out some of the nuclear receptors that were differentially expressed. There were 168 ACCs here, 51 benigns and 38 normal adrenals, and blue is low expression across the data set. Let me try and use this pointer. Yep, and red is hot expression. These are volcano plots basically comparing normal adrenal versus ACC or benign versus cancer, and again pulling out some of the nuclear receptors of that 48-member superfamily. So I won't tell you about which ones they were at the moment, but glucocorticoid receptor was overexpressed, and that has been shown in the literature, and steroidogenic factor 1, this is another nuclear receptor, which is an orphan that, as one was cried, basically is also overexpressed. We then took patient samples and did a TACMAN low density array of 47 of the 48 nuclear receptors. These are samples that Professor Alt and Christa Ronke at Birmingham provided us with to try and validate some of these initial nuclear receptors on the bioinformatics screen. And there's clear separation in blue of the ACC samples in terms of the nuclear receptor profiles, and that's a heat map representation. And then we pulled out, comparing the bioinformatic analyses and our own patient samples, albeit small n numbers, the druggable nuclear receptors that were found on both data sets, which included LXR alpha, a lipid sensing receptor, retinoic acid receptor alpha, and ER and estrogen receptor, and 3 orphan nuclear receptors, which are more difficult to study. But interestingly, from that small diagram here, they have been described as being differentially regulated and expressed in other types of cancers. Nevertheless, I'm just going to tell you about LXR, which is one of the druggable nuclear receptors. And LXR is important because actually it's a cholesterol sensing ligand-dependent transcription factor that's normally activated by oxysterols, which are oxidized cholesterol metabolites. They regulate sort of all aspects of lipid biology in normal health and act as a typical nuclear receptor. I won't go into the mechanisms. They're slightly complex in the sense that they regulate different aspects of lipid balance, bile acid synthesis, cholesterol efflux processes through these pink genes, ABCA1 and ABCG1, lipogenic pathways, and phospholipid remodeling. So step 1 was really to go to the Cancer Genome Atlas, which has 92 ACC samples, and look at survival data and progression data of ACC when you look at LXR. So LXR, there are 2 isoforms, alpha and beta, and obviously we had found that alpha was altered in our initial data. This is tiny, you can't read it, that's okay, but this is a forest plot of survival using the TCGA data, and all I really want to flag up is again that LXR alpha was differentially abundant between, it differentially expressed in terms of survival grades in ACC. So next steps, we went to patient samples again. I've shown you that very quick aspects of LXR regulated genes around lipogenesis, cholesterol efflux, and we looked at those said genes in, again, a small number of benign adenomas and ACC, and found some of those LXR target genes were downregulated in ACC compared to the adenoma. And BUB1B, which is here, is a gene that's overexpressed in ACC. So that was a bit of our sanity check gene to look at. And we're trying to follow this up with protein expression with immunohistochemistry to look at some of these LXR targets and their expression in ACC samples compared to benign. Finally, for my last couple of minutes, I'll just tell you a little bit about some of the work we've been trying to do to understand LXR pathways. So step 1, it appears that LXR is differentially expressed in ACC compared to benign. And there's some differential changes between the different isoforms. I won't go into that. Step 2, we've shown that LXR target genes are downregulated in ACC. And we wanted to try and understand a bit about LXR pathways. There are a number of pharmacological agents available to activate LXR, GW3965, a pan-LXR agonist, RGX104, which is in a clinical trial for other solid malignancies, and an inverse agonist of LXR, SR9243. Treating H295 cells is your typical adrenocortical cell line that's in use, and we've got some other cell lines that we're working on. We were able to at least show that with LXR ligands, agonists, we were able to upregulate expression of ABCA1, a cholesterol efflux gene, TREB-BP1C, and that was also shown at protein level. In trying to understand it in more detail, we're following up on gene and protein expression studies by taking on lipid stains. So clearly LXRs regulate lipids and efflux and lipogenesis. So we can look at Bo-Dippy dyes, which basically are lipid droplet dyes, but be more specific with mass spectrometry imaging, which allows us to have a very targeted approach, which lipid, and get some abundance data. And we're also looking at lipidomic data using global LC-based approaches alongside proteins. So that is treating cells with the GW3965, the LXR agonist, compared to vehicle control, and then trying to bring all of the story together. So that's just a bit of a work in progress. But I'll tell you a little bit about the lipids. When we treat H295 cells with GW3965, there are changes in lipids, unsurprisingly, in these cells that we can profile and get abundance data. And there is a shift in lipid classes with regards to the treatment compared to control. And we can identify some of these lipids. Far left of that column is basically the mass to charge ratio. what lipid it is, and then log two-fold change and the significance. Alongside this, we're doing multi-omic assessments, so looking at proteins, so same cells treated with same ligand, what happens to the proteins, and which of those proteins, which are up or down regulated in these cell lines, are related to lipid metabolism, to join the dots and build more of a story to understand what LXR is doing. And this is a table just focusing on things like fatty acid metabolism and other glycerophospholipid metabolism aspects, some of the genes as the proteins that we've identified in our data sets. And we can bring that together with protein and lipids together, same cells, same drug, what proteins, what lipids, and try and data integrate this, which is always a challenge with multi-omic data sets. So I'm running over. So our nuclear receptor screen, early days, show that there are 6 key nuclear receptors, 3 druggable, that seem to be differentially expressed in ACC. We've been able to show that there is some dysregulation of LXR pathways. Early days, small cohort. LXR pathways are active in ACC cell lines, and we can manipulate them not only to change the lipid milieu, but also understand which of those lipids might be oncometabolized. I haven't had a chance to tell you that lipids can drive cancer, and certain things like ceramides and other sphingolipids are bad lipids. And so we're trying to understand that in more detail and then test that functionally in the lab with cell lines, but also hopefully more patient relevant models. So thank you very much for your attention, and I'd like to acknowledge Professor Bevan running our lab.
Okay, one quick question. We are making up our time.
We have already experienced in other cell lines, because now certainly you strict.
I've only shown you HTN5 because of my 10 minutes and my speaking at 70 miles per hour, but we have been using the MUC1 cells with constans just to look at mitotain. So what I should say, these are mitotain sensitive lines compared to MUC1, which is what Professor Fasmat's mentioning. And then we are thinking about the Colorado lines as well.
Cool, huge body of work. Thanks so much, Eva.
Thank you. Moving on to our next speaker, James Hawley from the MRC LMS. And I understand the title is different, so I want different from the program.
No, it's Joshua. No, it's not him.
Oh, it's the correct title, I was told.
Yeah.
So it is going to be implementation of urine-associated metabolomics for the detection of CC.
Thank you.
So I'm going to share that with you.
Nope.
So it's not here. It's here. It's not here, bro. There's a note.
You can't go there.
It's different. Oh, yeah. Good. Yeah, and I can see it. Probably don't show it.
No.
Yeah, you can get them out.
You should be in the, there's one of those who does it, but like, if you see your mouse.
Hey. Oh, you had it.
Almost.
Yes, but it's not allowing.
How's it go? Now go there.
Yeah. But it's not here.
Okay, take them out.
Yeah, you understand, there's a mouse, there's a.
Oh, yeah.
No, this one.
Yeah.
Yes,
Okay.
We got there in the end. Thank you, and thank you, Vibeke, and thank you, Florian, for inviting me to speak. So, yeah, okay. Thank you, Vibeke, and thank you, Florian, for inviting me to speak today. So, I'm going to be talking about urine steroid metabolomics and what we're trying to do to improve the diagnosis in clinical practice. So it's a pleasure to speak to a room full of adrenophiles. I don't know if there's a collective noun for you all, but it's an honor to be here. As you know, the adrenal has multiple regions, so the medulla is principally concerned with the release of metanephrines, and for our part, we're interested in the adrenal cortex, where a lot of the interesting steroidogenesis occurs. So this is where we get all the major hormones that help maintain homeostasis, so aldosterone, cortisol, testosterone, which I'm sure you're all familiar with. Unfortunately, the adrenals have a propensity to form nodules, and these can be either benign adrenal corticoadenomas or malignant adrenocortical carcinomas. And it's very important that we can differentiate between the two. So a lot of these masses are picked up incidentally, hence the term incidentalomas. And so not when people present with symptoms, not when people come for cancer staging or follow-up. As you can see from this graphic from Irina Bankos's group at the Mayo, the majority are picked up incidentally when they're being reviewed for other conditions, and they'll have a CT and they'll find a mass, and then this mass needs investigating. So in the UK in 2023, 7.2 million abdominal CT scans were performed, and typically 1 in 20 of these will detect an adrenal mass. 1 in 20 of these will be found to be malignant ACC. So this represents a significant diagnostic problem to healthcare. We're left with the question, is it benign or is it malignant? So in the current diagnostic pathway, we have imaging where we can look at the size and we can look at the density of the mass. We also have select biochemistry tests where we can look for particular markers, as mentioned earlier, so cortisol, aldosterone, testosterone. So these are end products of steroidogenesis. This leaves us with a highly sensitive, but not necessarily that specific approach. So we get a very high false positive rate. We're then left with a diagnostic quandary of whether we operate or we leave the patient and see if this develops into anything more sinister. This is a dilemma. Surgery is invasive, and approximately 1 in 200 patients will suffer an adverse outcome when they go under the knife. On the flip side of this, adrenal cancer has a very poor 5-year survival rate. And as with most cancers, the earlier it's detected, the more confident we can be of providing a better outcome. So we're left with the question, can biochemistry do any more? When we think of urine testing, this has evolved over the years. So way back in the 1600s, it used to be that urine was we'd look at the turbidity, we'd look at the colour, we'd look at the smell, and sometimes even the taste, hence diabetes mellitus. But things have evolved since then, and back then they did not have access to mass spectrometry. So if we're now able to look at the wider steroid metabolome and look at this more holistically, so we can look at precursors and we can look at intermediates of steroid synthesis. A lot of this early work was pioneered by Cedric Shackleton, and this was performed using GCMS, where we can see a wider profile of glucocorticoids, mineralocorticoids, and androgen metabolites. So how does this link in with ACC? So when we think of normal adrenal cells that have got well-defined enzymatic machinery, we can look at identifying end products, androstenedione, cortisol, aldosterone, and testosterone. However, in cancer, essentially all bets are off as the enzymatic machinery is less well-defined, and we can then postulate that we will see more of the intermediates, more of the lesser known metabolites. So if we were to measure these intermediates, does that provide further diagnostic information, i.e. a different steroid profile? So in a lot of this work was pioneered by Wiebke, and in a proof of principle study, she took 102 ACAs and 47 ACC samples, and these were analysed using GCMS. and the profiles compared. It was then also fed into a machine learning algorithm, and this was able to identify 9 very relevant markers to confidently detect ACC and differentiate it from ACA with a 90% sensitivity and specificity. This was published way back in 2011 in JCM. If any of you have used GC, you'll know it's not really, not always conducive to high throughput analysis, and it can take several days really once you've gone through derivatization, analyzing samples, processing samples before you can produce a result. So there was a drive to try and translate this to LCMS, which is higher throughput technology. You can see this was successful. We've moved from 31 GCMS steroids down to a 15 steroid profile. And you can see these on these graphs on the right, so GCMS versus LCMS for the 99 ACAs and the 40 ACCs. There's clear demarcation between the two profiles. So this was the proof of principle study, and this led to a prospective study. So this is the URINAC study that was conducted over several years, over 14 European centres, of which I believe Martin was involved and helped provide samples. And this collected 2017 samples that were representative of adrenal masses as it was done prospectively. So the statisticians involved said we needed a 5% representation of ACC. So there was some dispensation around this, and they've allowed 4.9 for this to be significantly powered. And then we analysed these using the LCMS method, and we can compare different test strategies of urine steroid metabolomics using the traditional approach of tumour size, tumour density. So you straight away from this, using each test individually, you can see that urine steroid metabolomics provides a improved specificity. So we were able to reduce the false positive rate compared to traditional approaches. We then double everything up and look at the permutations of this. Again, you can see that using urine steroid metabolomics along with tumour size provides a very powerful approach to further reduce false positive rate and maintain true positive sensitivity. Obviously, the next step is combining all three, and you can see this is superior once again. So this is enhanced looking at tumour size, tumour density, and urine steroid metabolomics. This provides the most powerful approach to confidently diagnose ACC. This was written up and published in The Lancet in 2020. So we've successfully discovered, verified, and validated the test, and we're then left with the problem of trying to translate this into clinical practice. And this has a number of challenges. So we want to talk about how many steroids we can concentrate on. So do we want a profile of 15 steroids? If you speak to any biochemistry departments that offers mass spectrometry, this is not routine. Anything greater than maybe 3 analytes we will typically struggle with. We want to address concerns about traceability. We need a mechanism to ensure that this has quality controlled, and we can be confident of the results over the course of time and in different locations. And we also want to strive towards having the assay accredited under ISO and MHRA. So one of the beauties of using the machine learning approach that we've adopted, so the GML-VQ, is we can look at the relevance of the particular steroids. And this makes it slightly unique and different from other approaches. So we can look at all 15 and we can see the steroids that are most prominent, most relevant to that profile. We can then address this by looking at different permutations. We can reduce it. We can see which steroids are relevant with a smaller panel. and again, which are progressively reduce the panel to see which is most powerful, most prominent in the diagnoses. And this can then be translated to area under the curve, and you can see if we have 15 steroid profile, we get slightly poorer diagnostic performance than an 8 steroid profile. And equally with 4 steroids, this is poorer than 8 steroids. So it's almost a case of having too much information with the 15 steroid and too little information with 4 steroid. So we can settle on an 8 steroid profile, and this is achievable really for routine biochemistry departments. Next up, we want to look at the traceability of this. So when we talk about traceability in biochemistry, we're principally concerned with how accurately we can measure things and how that result relates to the units from which we are trying to derive it. So things like cortisol are very well characterized. They've had reference material available since 1972. There are multiple providers of reference material, so we can be confident that when we produce calibration material, we are quite close to the true value, and there are methods that we can use to assess this. When we look at some of the more esoteric steroids that we're interested in, they're only usually available from one particular provider, and we have concerns over the traceability of this because we see variation every time we produce different standards. This is obviously a concern if we are going to be using this as a diagnostic test. So one of the primary outcomes of this is to try and improve the traceability of the assay. We obviously are relying on a machine learning algorithm, but if we feed rubbish into this, there's only so much it can do to still produce the right result. So we do want to ensure that everything is standardized. So the answer to this, I believe, is looking at quantitative nuclear magnetic spectroscopy. At LMS, we are fortunate enough to be partnered with LGC, so the laboratory of the government chemist, and they are well practiced in producing standard reference materials, and they utilize QNMR for this. So we're working with the team at LGC, and they're looking at some of these steroids for us. So this is a very powerful process. So it's kind of like MRI, but at the nuclear level. So we can look at functional groups of the steroid. We can use it to assess concerns about solubility and impurities. So you can see we're able to identify low-level impurities using this technique, so we can get an accurate idea of actually how much is in our standard of interest. This is all additive to helping produce well-characterized reference standards, so that we're confident over the course of time that every steroid is producing the correct result. And this obviously enhances the machine learning algorithm as we can be more confident final results. This is especially important as we're hoping to site this assay on multiple sites. So we want everything to be traceable, but if we're feeding into one unified machine learning algorithm, we need everything to produce the same results over the course of time. Yeah, so we are slightly further along the road to accreditation. We're hoping to have some final standards from LGC later in this year, so we can reanalyze some of the urine samples and just ensure that everything is as calibrated as it should be and anchored to these NMR standards, and we're then able to hopefully go live with this and provide you with this service. I will leave it there, and if there are any questions.
Thank you, James. That's a fantastic overview. So once you've got a steroid fingerprint, then the patient had surgery. So you can use this to screen for recurrence afterwards.
It can. So,
how often would you do that?
How often?
What frequency?
I think the frequency is, there's still work to be done on the frequency. I would think three monthly initially, extending over the course of time to 6 monthly, and then hopefully progressing to annually. But this is preferential to imaging, so having the patient back for re-imaging or non-specific biochemistry testing.
Another question would be these 24-hour urine collections are quite cumbersome for patients.
They are.
And what are the alternatives? Can you do it in a spot urine?
We have got spot urine that we've collected with UrineAct, and we are currently analysing this. We've done some serum analysis, preliminary serum analysis, and this is less powerful than the 24-hour urines, which you may expect. We've had a cursory look at combining serum and 24-hour urine results. This is perhaps the most powerful approach, but it would also be the most difficult with the analysis. That's not to say it wouldn't be an option. So we'll look at spot urines as well. So maybe spot urine and serum would be the most powerful, but hopefully we'll have this data for you soon.
Thank you. Any other questions?
A question regarding the your idea is that you get it reimbursed. And would this be, so if everything is perfectly established, and then as a diagnostic test, would this then also relate to his question that in case of recurrence, looking for recurrence, this would also be reimbursed, or how would it work in your system? How would you finance this? It's obviously not the cheapest method.
What's the cheapest method?
It's not, okay.
There has been a cost analysis done on this, I believe, and this is the most cost effective.
For diagnosis, the health economics shows that this is a dominant test and that is massively more cost efficient. Yeah, like then repeated imaging, which has poor specificity. But for recurrence detection, we need a large scale study, which is currently in preparation, ACC Protect. Yeah, where Vasilis and I collaborate. Yeah, because Vasilis, when he was still a postdoc of mine, has published a proof of concept paper. Yeah, and we will do the large scale study with an LCMS assay, and then show how sensitive it is. Yeah, but obviously the proof of concept study is very promising. Yeah, and basically I would be more radical because it's non-invasive. I would do this monthly. Yeah, like sort of, and then retime imaging if I get a positive signal. And in the proof of concept study, we have seen a signal going up, steroid signal in patients who had a single less than 1 centimeter lung metastasis. Yeah, so I think it will be very sensitive, but this has to be proven in a larger scale study. Yeah. Cool. Thanks so much.
Thank you, Vika.
And James is our first part-time Jane Flory fellow. So 50% Manchester as a clinical biochemist and 50% PhD student through the Jane Flory scheme here at the MRC Laboratory of Medical Sciences. Cool. And the next talk is on integrative bioinformatics. Oh, do we skip it? I don't know.
No, it's
so one is Joshua. Program that is okay.
Joshua. I think.
So we skip one. Okay.
No, he's here.
Oh,
Yeah,
Joshua. Okay,
yeah.
sorry. We had the wrong volunteer. But Lina, you will still have your turn. So no, it's Josh Aglinko, who will be talking on integrative bioinformatics analyses to identify novel biomarkers and tissue-specific targets in adrenocortical cancer.
Thank you. So I'm Josh Aglinko. I'm a general surgery and endocrine surgery fellow, working here at Hammersmith, and also doing my PhD in Professor Charlotte Bevan's lab. Got some of my other supervisors here, Professor Karen Miran and Dr. Sheba Jarvis, and also close mentoring from Dr. Florian Bernig, of course. So the aim is just to briefly talk about some of our in silico approaches. incorporating some deep learning techniques. Okay, is that better? Thank you. Okay. So the aim is to briefly talk about ongoing in silico approaches where we're incorporating some deep learning techniques and some bioinformatic analysis to identify and characterize some key differentially expressed genes in adrenocortical cancer. So the aims are threefold. So firstly, looking at databases with ACC and benign, looking to see if we can identify some of these genes. And based on some work that's been done previously, firstly by Weiss and colleagues in 1989, where they looked at 21 adrenocortical cancer cases, and also work done by Zheng in 2017, which Professor Martin Fasnacht is an author of as well, where they looked at 92 adrenocortical cancer cases. And then they tried to characterize these patients into distinct groups based on their immune profiles. So the aim was to explore that and then see if we can identify further genes in that. And then hopefully, as a clinician, see if some of these genes are important, taking forward, validating them in the lab, and then also if they can serve as potential biomarkers for our patients. So this is just a pipeline of how we got from the data sourcing all the way to then arriving at our analysis. So the data, there were two databases. So one was from the genotype tissue expression database, where we got our benign patient samples from, and TCGA, or the Cancer Genome Atlas, where we got our malignant tissue samples from. And just to say, these are all RNA sequencing data. And then from that, we extracted key features that we wanted to actually look at. So these were mRNA expression, protein expression, methylation data, and also outcomes on patient survival. We use some data pre-processing techniques to normalize and also harmonize our data using principal component analysis, etc. And then some techniques such as the lasso and thresholding and autoencoding to try and reduce the dimension of these large databases that we've got, and other spectral clustering methods as well. And of course, we then use all these to then identify our differentially expressed genes, and then did some correlation and functional pathway analysis of such. So in the end, there were 258 patient samples in the benign group, and in the cancer group, there were 92 patients. And this is a breakdown of the data that we then extracted from these databases. So for example, in the mRNA expression group, there were 20,531 genes, and in brackets is the number of patients from the 92 patients. The first thing we did, of course, was to do a principal component analysis to make sure actually the genes that belong to the benign cohort belongs there, and of course, respectively, the ones that belong to the cancer cohort also belongs there. Clearly, with a variance of 88%, that was true. We then did an analysis called a principal component analysis of just the ACC cohort. And what I mean by that is actually, because you've got such a high dimensional TCGA database, you want to see the individual important genes that you can then look at the survival outcome from. So each dot does not actually, it's not matching up to the number of PCs. Each dot actually matches up to how the distance or the variance between the key genes that you then look at for your final analysis. So there were 20 PCs from the mRNA group. From the protein group, there were 30, and the methylation group, there were 25. And we managed to maintain the variance of about 78 to 92% across these three databases, or these data sets rather. In terms of dimensionality, again, it was then to extract the key features that we needed from the mRNA, from the protein, and the methylation group. And when we did that, we incorporated a variance thresholding technique, a lasso technique, as well as what we call an autorecorder loss and gain curve. And in the end, there were 49 key features that were extracted across the four data sets that we looked at. And that is a multi-omic intersection of the patient's graph on the left of the screen there. So when we then looked at which of these genes were then significant and which ones were significantly upregulated and which ones were significantly downregulated. There were 1,962 that were significant. And there were 1,012 that were upregulated with the rest downregulated. I've highlighted two of these here. One is the C19OFT1, which is very important generally in the normal cell cycle, and it's important for mitotic spindling and chromatin formation, etc. And as you can see, that unsurprisingly is expressed higher in the benign group, as opposed to one called FATE1 gene, which is highly expressed in the ACC group, which is activated mainly by steroidogenic factors such as SF1, and that is highly expressed in a lot of cancer cells, including colorectal cancers, ACC, etc. And that means there's increased survival of these cancer cells, and that drives mortality upwards. We looked at, and we tried to also come up with some of genes, not only genes, we looked at microRNAs, as well as something called lock genes. So these are genes that we do not know the function of at this moment, but we've included these to highlight the total number of genes as well as other non-coding RNAs that we derived from trying to get to differentially expressed genes across the ACC and benign group. We then did functional pathway analysis. So we looked at the Kyogo Encyclopedia of Genes and Genomes Pathways, or the KEGG pathway. And unsurprisingly, most of these genes are involved in ribosome and spliceosome. So these are the normal cell machinery, We also looked at reactome pathways, and some of the important ones to highlight are the histone deacetylase pathways, which obviously there are ongoing and promising results from inhibitors that are being used in some cancers such as thyroid cancers, etc. And also we looked at geo enrichment pathways as well. And as you can see, a lot of them are involved in a normal cellular transcription processes. What was also interesting was also then breaking these down according to the actual function of these genes as well. So we looked at something called disease gene network, and then that essentially allows you to look at the genes themselves in relation, so in ACC as well as genes in other cancers. And you then are able to then look if there are any overlapping genes between different cancers as well. Some of the ones that we came across, important transcription factors such as STAT3, and which Dr. Shiba Jarvis looked at as well, as very important to her, which is one of the key transcription factors that came up. There are also very important kinase enrichment analysis, some of the genes that came up, such as CDK, L-cyclin-dependent kinases, and AURKA, which are all important genes in ACC and other cancers as well. The next thing that we did was, in the ACC cohort themselves, we tried to do a clustering analysis. And what this is showing is, we try to see if, based on the individual databases from the TCGA, if we're able to split them into two clusters based on their immune profile. So on that screen, you will see a blue dots, which are corresponding to all the databases that were clustered in the C0 group, which I will talk about. And there were 19 patients in that group. And then in the C1, there were 27 patients. The number of genes that were upregulated in that C1 cohort were 321 genes. And those that were downregulated were 246 genes. We then looked at the top 10 differentially expressed genes in just the ACC cohort to see if we can then split them further into the cluster 0 and the cluster 1. So I've got a Spearman correlation graph as well as a Saki diagram there. And what that is showing where, based on protein expression of these genes, whether they belong to cluster 0 or cluster 1. So for example, if you look at survival of cluster 0 versus cluster 1, clearly there is differentially survival outcomes in these two clusters. For example, in the cluster 0, you will see there is reduced survival amongst them compared to the cluster 1. And actually, when we then looked at the individual genes that were expressed at the protein level, using TROAP as an example, which is highly expressed in the C0 group, you will see that actually it is more associated with increased, reduced mortality in that group. And the reason why, when we did a deep dive into that, you will actually see that with the genes that were in the cluster 0 group, they were highly associated with immune infiltration, such as CD8 T cells and fibroblastic cells as well. So again, based on the clustering of the ACC cohorts, whether they belong to C0 or C1 group, we're able to classify these genes into these two clusters based on their immune infiltration. So in conclusion, using a multi-omic approach, obviously this is without lab validation as yet, we're able to come up with some key differentially expressed genes in ACC, look at some of the roles and some pathways that are important. And that was also, we're able to also recluster some of these genes based on the good work done by Weiss and Zeng papers as well. And this is hopefully going to form a scientific basis for further laboratory work to try and explore these genes further from a gene and protein expression point of view. Thank you.
Okay. One or two quick questions.
While we're waiting, so that lovely talk, thank you very much. Have you got any plans to validate this in human tissue collections?
Yeah, thank you. Yeah, we do. So we have plans to do so. At the moment, we're working mainly with cell lines, the H295 bar cell lines.
But your immune phenotype, I think, is really interesting, but you need that validated in human tissues, don't you?
Yeah.
Your
And
cluster 0 and cluster 1.
yeah, and there is plan to do so in human tissue as well.
Thanks very much. There isn't huge amounts of data available on TCGA in terms of clinical data. Do you know if there's other factors like R1 resection or the size of the tumor that may have accounted for the difference in survival other than just the differential gene expression from the analysis you've shown us?
Yeah, correct. So from some of the NSAT data from NSAT, etc., so there are key drivers from a diagnostic and prognostic point of view that influences the outcome for patients. So we have not actually demonstrated that in the data I have, but clearly I think there will be. I think the immune part is, I think, separate to, the R0 resection, some of the surgical outcomes.
Okay, thanks so much, Josh.
Thank you.
Thank you. This takes us to a last speaker for this morning's session, and that's Lina Schiffer from the MRC LMS, recently moved here, and I think you've got a different title.
Do I?
No?
Is that different from what I think? I don't know.
It seems to be someone has, but it's all good. Okay, so your title is going to be Metabolic Coordination of Androgen and Glucocorticoid Action by 11-beta hydroxysteroid dehydrogenases.
Yes, that's it. Thank you. Yeah, as you might have noticed, I'm eager to break for lunch. We have the lunch is already being passed around, so I'll try to make this quick. I'm going to talk about how the tissue-specific metabolism of androgens and glucocorticoids by 11-beta hydroxysteroid dehydrogenases or 11-beta HSDs functions as kind of a switch that either promotes androgen receptor action or glucocorticoid receptor action. And I just want to point out that while I'm at the LMS since just this Monday, this work was done while I was a research assistant professor at the Urology Institute at the University of Miami. So I want to start by just revisiting the well-established functions of the 11-beta HSDs for the regulation of glucocorticoid receptor action before I go into some of the new functions for the regulation of androgens that we have discovered over the last couple of years. So as you will know, our adrenal gland makes cortisol, which can activate the glucocorticoid receptor, which is a ligand-activated nuclear receptor, which then goes and regulates its target genes.
and in mineralocorticoid receptor target tissues such as the kidney, 11 beta HSD type 2 can actually inactivate cortisol to cortisone to prevent excess activation of the mineralocorticoid receptor. And then in other tissues, such as the liver or adipose, the other isoform of 11 beta HSD, that is 11 beta HSD type 1, can reactivate inactive cortisone to cortisol. And then as you will also be, or as you will also know, the adrenal gland also makes a lot of the androgen precursor DHEA, which through pathways of peripheral metabolism can be converted to classic androgens such as testosterone and DHT, which can then go and activate the androgen receptor. But the adrenal gland also makes a lot of this compound called 11-hydroxyandrostenedione, which is the universal precursor to a new class of active androgens, which we call 11-oxygenated androgens. And these are produced also through peripheral metabolism. And I was fortunate to be able to contribute to the discovery of these peripheral activating pathway while I was working with Wiebke at the University of Birmingham, and also with our long-term collaborator, Karl Storbeck from the University of Stellenbosch. And actually, these pathways also involve 11 beta HSD type 1 and type 2. So this is where you see the overlap of glucocorticoids and androgens is coming together. And I want to show this a little bit more using the structures of the compounds here, where you can see cortisol has this 11 beta hydroxy group, which is then converted to an 11 keto group by 11 beta HSD type 2. So that activates the glucocorticoids. And then for 11-hydroxyandrostenedione, it shares this 11 beta hydroxy group that cortisol has as well, which also makes it the substrate for 11 beta HSD type 2. And this then produces this compound called 11-ketoandrostenedione. And this is the direct precursor for the generation of 11-ketotestosterone, which is an active androgen that activates the androgen receptor with similar potency and efficacy as testosterone. And then 11 beta HSD type 1 catalyzes the downstream metabolism of 11 ketotestosterone and inactivates it again. So here you can see that while type 1 11 beta HSD activates glucocorticoids, but inactivates androgens, 11 beta HSD type 2 would activate androgens but inactivate glucocorticoids. So this is where this kind of balance between androgens and glucocorticoids starts to happen. To summarize this here, there are opposing effects of 11 beta HSD metabolism on the bioactivity of glucocorticoids and 11 oxygenated androgens. And so just to give you a bit of a flavor of how relevant these 11 oxygenated androgens are, I just want to point out here, this is from a study that we did back in Birmingham, where we recruited healthy volunteers, and I'm showing you the data for the women we had in this cohort. Here you can actually see that 11-hydroxyandrostenedione, so that's the adrenal precursor for the generation of active 11 oxygenated androgens, circulates at levels that are comparable to DHEA, so it's quite relevant. And also 11 oxygenated androgens do not decline with age as opposed to classic androgens. So like I said, this pathway or its overlap would be relevant in tissues where we have both AR and GR expression. And as you will know, glucocorticoid receptor expression is relatively ubiquitous, and AR is more tissue specific. But here I'm showing you some examples where we have co-expression of AR and GR together with 11 beta HSD type 1. So that would be the liver and adipose tissue. But then other tissues like the breast, for example, which we've chosen as an example here to study this mechanism further, express GR and AR together with 11 beta HSD type 2. And like I said, we've studied breast as an example here because 11 oxygenated androgens are particularly relevant in women also. So we've used these ER positive breast cancer cell lines, T47D and MCF7, as a cell model to study this. So you can see here they have both AR and GR expression. And the first thing we did is to check which 11 beta HSD is active in these cells. And the answer is it's 11 beta HSD type 2. So if we put on cortisol, we get rapid inactivation, as you can see here, and we see the generation of cortisone. But if we put on cortisone, we do not see any regeneration to cortisol. And this looked similar for the MCF7 model. And we then looked at 11 oxygenated androgens, which we were pretty curious about because based on their gene expression profile, we speculated that they were very much able to generate those active 11 oxygenated androgens from the circulating precursors. And this is what I'm showing you here. So we've treated the cells with all 4 11 oxygenated androgens along this pathway. And this is color coded here. So the active compound is shown in red across all these schemes. And as you can see, whatever we put on, we always end up with the formation of the red stuff. So that's the active androgen. So if we put on 11 hydroxyandrostenedione, we see its conversion to 11 Ka4, the intermediate, and then generation of 11 ketotestosterone over time. If we put on 11 ketotestosterone, there's only a little bit of back conversion to the inactive precursor 11 Ka4. So everything seems to converge towards the generation of active androgens in these cells. This looks similar here in MCF7 cells. So going forward, I'm only showing you data from T47D, even though that is supported by some more data that we have for MCF7, but I'll skip that in the interest of time. So we wanted to figure out more than what the role of 11 beta HSD type 2 exactly is in these cells for regulating androgen receptor and glucocorticoid receptor activation. So we made the CRISPR knockout. You can see the activity tests here that we've done, the control, and then a few different guide RNAs that we've tested. We've picked our favorites here, confirmed the protein is gone, and we still have comparable androgen receptor and glucocorticoid receptor levels in our knockout and our control cells. And then we use these in gene expression experiments. And here, the first thing I've done for some time-dependent assays, I've looked at ZBTB16 as a nice target gene that is targeted by both AR and GR, so that I can look at basically have the same readout for the activity here. And what you can see is that if we put on 11 hydroxyandrostenedione, the inactive precursor, over time with our control cells, we will see induction of this gene in response to AR stimulation, but this is completely flat in our knockout. And so this really supports the important role of 11 beta HSD type 2 for the generation of active androgens from these precursors. If we put on the active compound here, that's the control, we don't see differences between the control and the knockout. And now if we look at cortisol, this is exactly the other way around compared to the androgen. So we put on cortisol, and then for both our knockout and the control, we see induction at the shorter time point, but then this is reduced with the control at 72 hours, consistent with the ability of those cells to inactivate glucocorticoids. And we do not see this with the knockout cells. So we conclude that 11 beta HSD type 2 knockout prevents the response, the knockout prevents the response to 11 oxygenated androgens, but sustains glucocorticoid action. I looked at this in a bit more detail, looking at a few other genes here, and we also have some more RNA-seq experiments ongoing here at the moment. So you will see if we put on the hydroxy compounds here, 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 and here, our knockout fails to induce a response to the androgen receptor, where we do see a decent response with our control cells. And for glucocorticoids, this looks the other way around again. So if we put on cortisol, we see a sustained response here with our knockout cells, and the response is gone in our control cells. So we then ask the question, what happened if we reverse the activity of the 11 beta HSD? So basically, as I just told you, we've taken out 11 beta HSD type 2 and look what happened. And here we're looking at what happens if we put 11 beta HSD type 1 back in. So that's the enzyme that would activate glucocorticoids, but inactivate the 11 oxygenated androgens. And we've done this by comparing the wild type enzyme to a mutant enzyme, which is still a functionally folded protein, but we've designed it in the way that it would actually catalyze the reverse reaction. So it kind of functions as a negative control in these experiments. And you will see here that if we put on cortisone and we have the wild type 11 beta HSD type 1 in the cells, we do see induction of ZBTB16, so our GR target gene here, but we fail to see a response with the 11 beta HSD type 1 mutant. Then again, for androgens, we see this the other way around. So we put on 11-keto-testosterone. This is the active 11-oxygenated androgen, as you will remember. And then if we have the wild type 11-beta-HSD type 1 in the cells, we see only very mild induction because this is inactivated to 11-hydroxytestosterone. But if we mutate 11-beta-HSD type 1, we see sustained induction of ZBTB16 in response to 11-keto-testosterone because we no longer see this inactivation. So I want to conclude that 11-beta-hydroxysteroid dehydrogenases function as a toggle between AR and GR activation. And in a context where we have expression of 11-beta-HSD type 2, this would favor AR activity over GR activity because the type 1 isoform will activate 11-oxygenated androgens but inactivate glucocorticoids. And then in tissues where we have primarily 11-beta-HSD type 1, we will promote glucocorticoid action but reduce 11-oxygenated androgen action. So then I want to go through a few implications of these findings because as Miriam asked me at our lab meeting this morning, so what does that mean? There's not this morning, on Monday, that there's a toggle between AR and GR. What are you trying to tell me? So basically what we would speculate is that 11-oxygenated androgens are functionally distinct from classic androgens like testosterone because they are active specifically in the absence of glucocorticoid action. We think this is a new tissue-specific metabolic mechanism that regulates or integrates androgen receptor and glucocorticoid receptor activation. So it's kind of an additional layer of regulation in addition to what people have studied in the past, the physical interaction of nuclear receptors at the level of chromatin. And we think it's just, important to consider these as a tissue-specific mechanism when studying steroid nuclear receptor action and their interaction, for example, in breast cancer, where GR and AR function in the literature is a little bit controversial, and then also, for example, in adipose tissue and liver and metabolic disease. So I would like to thank you all for your attention. And then I want to thank Nima Sharifi and his lab back at the University of Miami, where I've worked the past 2 years, specifically Katrina Lomas, who has helped me with a lot of the gene expression experiments. And then thank Wiebke and her group and Karl Storbeck, who's been a collaborator on everything 11-oxygenated androgens that we've done in the last couple of years.
Thank you very much. Any questions, any burning questions, because we are slightly late for lunch?
Do you know how this is functioning in lymphocytes? Is there because there's increasing interest in the antigen action in lymphocytes?
We have done those experiments. So we have, oh my gosh, we have, I think, not seen a lot of 11-beta-HSD type 1 activity in any of those cells, a little bit of 11-beta-HSD type 2. What we see a lot is AKI1C3 activity in natural killer cells. So that would be the last step that makes 11-keto-testosterone from its precursor. That seems to be a very active pathway in natural killer cells. But that is in circulating cells. We have not looked at this at a tissue-specific level or so, yeah.
Really excellent talk, so fascinating. I just wanted to ask you about some of these, obviously, androgen metabolites and thinking about other nuclear receptors, because there's obviously some evidence around other nuclear receptors, androgen metabolites can obviously activate them. And it's a really neat story with the ARGR, but I just wondered if what your thoughts are on that.
So for the 11-oxygenated androgens, I believe Karl Storbeck's lab has looked at all the traditional steroid receptors, but I'm not aware of any work that anyone would have done looking at other nuclear receptors.
This might be something to think about with the metabolic angle. Certainly things like androsterone and other androgen metabolites can activate things like FXR.
Yeah, no, that's really cool. Yeah, absolutely.
Okay, any more questions? If not, then I would like to thank everyone for a fantastic morning.